I'm in the door. I'm in the sidewalk. Ready, set, go. Hi. You're good. I'm just going to call you when you sit. Is this going to be in any way obvious to me? How to do this? It's on? Really? People can hear me in the back? Probably not. Okay. You're the conference coordinator, aren't you? Okay. Well, I'm going to introduce you. So how do we turn this up so people can hear me? Is there a volume thing so I can call people in? All right. Okay. Good morning, everyone. I'm still enjoying all the conversation going on. I'm reluctant to call you to your seats, but now is the time. So while you're in your seats, I'm just going to make a few welcoming comments. I am, as many of you know, Valerie Assassin. I'm currently the MAWS president, and it is one of the pleasures of the MAWS president that I get to stand up here and look like I had something to do with this conference. Well, in fact, we have this spectacular volunteer conference committee that has really pulled it off beautifully. Hopefully, those of you who completed your fall member survey will recognize that we heard your call for clinical content loud and clear. This is pretty much a fully clinical day, and hopefully that will satisfy your call to action. I think looking forward, you can anticipate that the fall conference will specifically be focused on business skills. The business of midwifery was the second call to action on that beautiful survey. So a few things. I want to welcome all of you in person, but we also have quite a number of people live streaming today. The conference committee has made it possible for people in person here to eat and get CEUs, but anyone anywhere can live stream via YouTube today. Those of you who are live streaming in, a couple of notes. One, there will be a lag, so don't be alarmed. Two, today's events will automatically be saved, so anyone here or anywhere who wants to watch later, they'll be available on YouTube. Is there anything else, Tara, about that? Okay, great. I want to introduce our spectacular program director, Amanda Anderson, because we were not able to present her at the last conference. So raise your hand. This is Amanda Anderson. She's our MAWS program director, without whom I would not have courage to get up in the morning. So really, please say nice things to her all day. That would be great. The thing that I'm most excited about our membership today has yet to reveal itself in this room, but we have had an unprecedented number of babies in our community. Not babies we're catching necessarily, but midwives with babies. So babies on the way, babies just had, and I am hoping that many of them will come today because I think it's incredibly exciting. What else do I want to say? I want to say thank you to the speakers who have yet to arrive. I want to say thank you to the sponsors, many of whom are here in person. I want to say thank you to the vendors. Please visit them often and make conversation. The caterers are doing beautiful work. The Mountaineers always take great care of us. But really, the people that we need to take our hat off is to this incredible volunteer conference committee. So many of them are sitting here at the table. If you're on the conference committee, will you stand and give a wave? And people should say thank you to you all day. Oh, good. Okay, perfect. Again, volunteer conference committee working their tuchuses off. So led by Amy Shaler, who is our volunteer conference coordinator, who I'm going to step aside and let her speak now. Ready? Okay.
Good morning, everyone. We're so glad that you could be here. I wanted to take a moment to thank all of our wonderful sponsors that are here. We have Southern Cross Insurance and, of course, Bastyr University, Orion Medical Supply, Nurturing Expressions, Radiant Belly, and PEPS, and then Client Care. So we're also happy that you could be here. Just another reminder, Val mentioned this, there is a bunch of orange papers in each of your packets, and those are for each session. If you could make sure and fill each of those out, keep track of those, because that does allow you to get credit for each session. At the end of the conference, there will be a box up at registration. You can just stick them all in there. And then within the next 2 weeks, you will receive your certificate. We also have 2 great raffle baskets that will be floating around. They're up at the front now, but they'll be floating around during break, and we will have 2 lovely volunteers walking around selling tickets for those. And at the end of the conference, we have our little wine and entertainment party in the Cascade Room at 5:30. If you haven't signed up yet, you can sign up at the front. It should be a really good time. Wine and karaoke and some good treats. So thank you all for being here, and I am going to welcome up our first speaker, Heidi Koss.
Are you guys forwarding the slides? Good morning. Can people hear me now? Are you guys forwarding the slides for me? Okay, sorry. Or I can, yeah. Here. All right. Good. Oh, shit. Alrighty. And it's back. And okay. Sorry about that. Hi, I'm Heidi Koss. I'm a psychotherapist in the, I actually practice over in Kirkland, and I specialize with perinatal mood disorders. Some of you may know me. And I'm here just to talk about how to work with mental health during pregnancy and postpartum, because we can't forget this part of the woman's body and the importance of how that impacts both her pregnancy and the birth and her postpartum experience. So I don't know how many of you knew statistically, I call them PMADs now, perinatal mood and anxiety disorders is kind of the lingo across the land now. Statistically, they're the #1 complication of pregnancy. 15 to 20% of women will experience a mood disorder, a mental health issue of clinical significant level starting during the pregnancy. About a third of the time it starts during the pregnancy or postpartum. I think gestational diabetes is 12%, and preeclampsia is 9%. Forgive me if I'm wrong. So, these kinds of things, we want to make sure that we're universally screening and checking in with these mamas. So how does this kind of begin? We're a combination of nature and nurture, biological, psychological, our environment. Are there a lot of stressors? Having a baby is kind of like an existential crisis for a lot of people. And plus the pressures, the mommy wars, the shoulds. I should be feeling this, I should be doing that, which I always say should and shame are 2 sides of the same coin. And that kind of pressure can impact our mental health. I have a lot of slides, so I want to book it through. So I want to really instill a lot of information. So genetics, mood disorders run in families. So I don't know if you guys are doing, and I'm making assumptions that most of you guys are midwives, but I apologize if there are other professions here, but I'm just going to treat y'all as clinicians in general. But getting to know if this is a subsequent pregnancy, did she have a mood disorder experience with a previous pregnancy? Does anything run in your family? Do you know of any mental health issues that are pre-existing for yourself? There's a spectrum. That's why we call them PMADs now, perinatal mood and anxiety disorders. We want to really get away from calling it postpartum depression or calling it postpartum, as you guys know. That is, we all are postpartum after having a baby. So it can be the spectrum: depression, anxiety, panic disorders. And anxiety is now documented with research as being as prevalent, if not more prevalent, than depression actually in the perinatal period. So making sure that we're really catching the anxious mom too. Obsessive compulsive disorder, about 9% of women will experience this. Bipolar disorders, sometimes it's a first onset that starts, that's finally the catalyst that flips on that genetic predisposition, or maybe they've had it before, sometimes it's undetected, as well as PTSD, whether they've had previous cumulative traumatic experiences or whether the birth itself becomes a traumatic experience, and then postpartum psychosis. So the biological, the neuroimmunological disorders are often an inflammatory response. There's a lot coming out. If any of you follow me on Facebook, like last night I was reposting too, about inflammation and mood disorders, and they go hand in hand. So we're also trying to track that. If you're noticing moms having chronic inflammation, pain, arthritic kind of symptoms, know that depression it's like this nature and nurture. Depression can be, or a mood disorder can be elevating that, or that in and of itself could be a precursor to having a mood disorder. So we also know that early postpartum is a state of serotonin deficiency. Serotonin is one of the important neurotransmitters regulating mood. Studies that show that women who have decreased tryptophan levels have increased depression rates. Cortisol, estradiol, progesterone all have an impact on serotonin in the system, and so they decrease precipitatively after birth, so we need to monitor these moms closely. They found, Yim at UC Irvine found a correlation between the rapid release of cortico-releasing hormones at 25 weeks during gestation and a development of postpartum depression. So really this biological component. And we're taking away a lot of shame, just doing simple education, letting these moms know this is a biological illness. It doesn't mean that you're a bad mom. It doesn't mean that you're not a loving mom, etc. It is out of your control. There is a huge biological factor. It is a medical, I wish they would, I have a big beef about mental health being separate than medical health because, hello, it is medical. Our brain is an organ. So anyway, this hormone is also produced by both, as you guys know, probably the placenta and the hypothalamus. So that's also why we also want to check a lot of the thyroid disorders too, with hypothalamus issues. And they can be comorbid just because they might have hypothyroidism, which is which can be correlated with depressive symptoms. They can also go hand in hand. So again, stats, 15 to 20% of pregnant and postpartum women experience some form of a PMAD. Like I said, anxiety can now be as or more prevalent than depression. And the rates, the statistics, 15 to 20% is in an average population. When we look at higher risk populations, such as DSHS, populations that have a lot more stressors in their system, some of the rates now are documenting 51%, half of moms and this is a clinically significant mood disorder. So we're talking epidemic. Every other mom, make sure that we are creating a buffering system to help catch and support these women. Also, don't forget the dads as part of the family that we're addressing. 10% of dads are experiencing a clinically significant perinatal mood disorder. Typically, and this is the sticky wicket, if they've been doing fine during pregnancy and initially postpartum, sadly, most of them have graduated off from our care. We're seeing a correlation at about 3 months postpartum is when a lot of the disorders actually finally hit. And that's after they've kind of been released from our care. So that's why education up front saying, hey, this can happen at any time over the first 12 months. It can be a late onset. Watch around, 3 months or so is a common time. It can even happen 6, 9 months later, but just letting them know and saying, if that's a problem, give us a call, or here's a pamphlet for the, PSI of Washington, call them. And are all of you familiar with PSI of Washington? That's Postpartum Support International of Washington State. It's a nonprofit. I believe we have a table here tonight. There's Mia, who's one of the head honchos. She's in the gray sweater with the dark brunette, waving her hand there. And that organization provides free peer mom-to-mom support through a warm line, educational materials. We'll send them a booklet, etc. And we have free support groups located all over the state with online. You can look up where the closest support group is for you, as well as there's a provider referral list. If you guys are wondering, who do I call? Where do I turn to a mom? The PSI of Washington website has pre-screened. We pre-screened mental health providers to be listed as a referral source. You had a quick question, yeah. Yes, it does. Both therapists and prescribers, as well as other groups in general. I believe there's naturopaths on there and some doulas on there as well. Some other new research came out last year tracking maternal depression in general. I just want to throw out, I know this is like beyond the perinatal period, but that it's more common at 4 years, again, 4 years tracking this issue. And we're seeing a lot of things about if women are not treated and addressed early on in the perinatal period, this is a disorder that can onset and last then for years and years. So like I said, about 1/3% or third of moms, the onset is during pregnancy. We do know, some research is showing about 40% of women resume medications during pregnancy if they already have a pre-existing condition and they're already working with a mental health provider. We also know if you have a pre-existing condition, 50 to 75% relapse during pregnancy if they discontinue their psychiatric medications. And what happens, sadly, is a lot of moms are like, oh my God, I'm pregnant. I just figured it out. And so they just stop without consulting their providers. And we actually show if they don't taper off the increased rate, the suicidal ideations come back very, very quickly. They might not even have suicidal ideations if they taper off. However, if you go off precipitously, that could be a symptom that they experience that they wouldn't have otherwise. And so we're trying to help work with them carefully. Suicide is the leading cause of maternal death. How many of you knew that? Not obstetric complications, suicide. Suicide. Again, this is the #1 complication of a pregnancy. Suicide rates go up 44% in the postpartum year compared to other times in a woman's lifetime. 44%. Again, this is an issue that is relevant to the care. We have to address this in pregnancy and postpartum. So I know some of this is, I just want to burn through some of this quickly, but what's the difference between typical pregnancy kind of issues versus, in this case, I'm comparing depression. So, kind of the moods, the ups and downs, but with pregnancy issues, it's severity and duration. Looking at severity and duration. Is it short-lived? If they can get rest and good self-care, does it restore them? Are they still enjoying things in life? Do they have an appropriate appetite? Do they have any sleep disruptions that are merely more because of, bladder and discomfort, etc., versus ruminations all night, versus hypersomnia, not wanting to get, there's the difference between first trimester like all of us go to bed at 6 p.m. and are dragging that first trimester, but then it should lift in the second and third trimester. Depression itself, again, more severity and duration. Anhedonia, that's like the meh nothing looks good, nothing sounds good, I'm not really interested, I'm not really motivated. I stop kind of going anywhere. I open the fridge and nothing looks good. I don't feel like doing anything. Increased levels of low self-esteem. Sleep disruptions where you often can't fall back asleep. Say you get up to go pee in the middle of the night, then you're up for the rest of the night, and can't go back to sleep. Anxiety, that hyper-vigilant mom that's worried about everything. I actually put a moratorium on my moms to get offline. I actually tell them, I'm prescribing you, do not Google anything. Do not go on Facebook, get off of Instagram, get off of everything. Do not go on that until further notice, and that really helps. Also, other symptoms, heart palpitations. They might feel like they're having a heart attack or arrhythmia, or they can't catch their breath. Diarrhea, GI disturbances. We're seeing a lot of issues with, your acid levels go up in your gut. Also, there's a high correlation with your gut biome, on an aside, your gut biome and mood. Serotonin is actually produced in our gut. And so when our gut is off, our serotonin is off and our mental health is off. So, probiotics is actually a very good thing to have mamas on when they are having a mood disorder. Panic symptoms, those panic attacks where people think they're having a heart attack. But the three greatest fears that we're seeing in women with panic disorders: fear of dying, whether themselves or their baby or their partner. Those are the three. Fear of dying themselves, their babies, their partner, fear of going crazy, and fear of losing control. And how many of us work with moms that want to be in control of everything? And exactly. And I must know this about the birth, and exactly. So that's really a challenging thing. So what kind of consequences if there's an unmanaged case? Poor prenatal care, poor follow through. They do have an increased risk of obstetrical complications, increased risk of prolonged labor, increased risk of C-sections, increased risk of stalled labor, increased risk of other issues. They will have an increased exacerbation of existing mental health issues. Also, their rates of substance abuse, self-medicating, can go up. And to top it off, impaired bonding, either the fetal bonding, the prenatal bonding, or postpartum, where not every mom, but we're seeing it can happen, and there is a higher correlation. So there's also this huge comorbidity. I have never seen a clean depression or just anxiety. It's always like everyone has their own little flavor. Some of it's like a lot of depression with a little bit of perseverating thoughts and some anxiety, or predominantly maybe OCD, but they're having lack of motivation, that anhedonia, kind of low-grade depression, etc. If you have PTSD, I actually probably should have not made these a little equal in this diagram, but PTSD, you kind of have all of the above, pretty high existing. So mood disorders. I also really want to talk about bipolar disorder really briefly, that this is the postpartum depression imposter. And it's a really tricky one because about half of the time, if not more, women present in that depressive phase. And so we think, postpartum depression, then maybe some docs or other providers will jump to, here's some Zoloft. And as many of you probably know, going on an antidepressant, SSRI kind of family medicine in an actual biochemical bipolar disorder can actually onset mania. Not always, but it can trigger postpartum psychosis, in fact, in some women, which is a medical emergency that would require going to the ER. So what are mood disorders? I just want to briefly, there's this spectrum. On one end, the like kind of lower grade and there's dysthymia and cyclothymia. I don't know how many of you are familiar with that, but I call those kind of the Eeyore disorders. Those are the people that they don't have mania, but it's more persistent depression and cycles of it that last throughout once it onsets, kind of your lifetime of depression and then like feeling normal, and then depression and then maybe feeling normal. And again, these women are more, if they have this kind of disorder, are more likely to have a perinatal mood disorder, an exacerbation of their illness during the perinatal period. And then there's bipolar type 2 and bipolar type 1. Just briefly, bipolar type 1 disorder is when you have the severe depressions, and they can be suicidal depressions or not. They ebb and flow, they can be different. But a bipolar type 1 disorder, the mania, that highs, lasts at least 7 days, which is longer than bipolar type 2. And the manic symptoms are so severe that they can often require hospitalization because they're psychotic features, either auditory or visual hallucinations or tactile hallucinations. Most people with bipolar disorders spend about 90% of their cycling time in the depressive phase. The manias it's not an equal 1-to-1 ratio. Bipolar type 2, depressive episodes can be just as severe as bipolar type 1, but you have hypomania, not mania, hypomania. This is where you might have more impulsivity or compulsivity, spending money, feeling a bit grandiose. I can take on this. I can do, the PTSA and, taking on a nonprofit and go to work and make all these meals, and then you crash. It's like being on a super caffeine buzz and getting all of this stuff done. Maybe you might have insomnia and you're getting 2 hours of sleep at night and you feel great. This is the mom that I really want to watch because she looks so high functioning. It's very misleading, but again, depression can crash. You can have rapid cycling where the phases are up and down all within one day or back to back. Sometimes a depressive in a non-rapid cycling depression can last weeks and weeks, and mania can last maybe a few weeks. But in the rapid cycling, we're going up and down, in some women hour to hour. So here's kind of like a rhythm there. The thing is too with bipolar disorders, we want to kind of short circuit this cycling really fast because the longer it goes unchecked, the kind of closer together that frequency gets, and the higher their highs can get and the lower their lows can get. And if they go years without treatment, it can become med resistant. Actually, there's a phenomenon called kindling that happens in the brain, which is, if kindling really starts, there's a certain level of irreversible, I just call it as metaphorically like calcification in the brain, and it gets very med resistant. So we don't want to let this go. We talked a bit about mania, hypomania, super, super high functioning in some cases. The crashes. And if anyone needs these slides, feel free to email me, and I'm happy to send you all of these so you can have for your reference. But the distinction is really important because most women are first diagnosed with bipolar in the postpartum period. They didn't realize maybe they had this. Maybe it was so light, kind of mild before children, and then having children is the final catalyst that flips this switch on. The other thing, unlike postpartum depression, anxiety, etc., some of those can go away. I kind of describe to my patients because they're like, am I always going to be this way? And I truthfully say, I don't know. I said mood disorders are kind of like diabetes. There's type 2 that you can kind of control with diet and exercise, and maybe it goes away over time. Then there's diabetes type 1, where your pancreas just went kaput and you're on insulin the rest of your life and you just need it. Mood disorders with pregnancy and postpartum are the same way. Sometimes it's an onset, and yeah, you might need some support for the rest of your life. Your neurochemistry is a bit off, and it's like having kind of anemia in the brain, and you need a little boost to help regulate your neurochemistry. For some women, it goes away, and for some women, it doesn't. If you have an onset of bipolar disorder, that is not going away. Once you have that onset, it's a management for life. That is a kind of like diabetes type 1 disorder. Again, clinical intervene. I know you guys aren't mental health people, but just, just getting a good, does this run in your family? Do you know if you experience this? Do you ever have times where you're feeling, super high highs? You can get all sorts of stuff done. Do you ever have times where you hear things that aren't there, or some people will, tell you that certain things they've experienced before, or seen things, or in rare cases, command hallucinations where they're being told to do something. Those are more rare. The typical psychotic can be really benign, actually. Just hearing music that is beyond an earworm of, a song that's been on the radio, but, kind of hearing something, it's not really there, but you can't stop hearing it, feeling your skin crawling, feeling a bit paranoid, like you're always thinking somebody's watching you, or paranoia can be, oh, that mom has a look on her face, she's judging me, she thinks I'm terrible. Really, that is like a really low grade paranoia that is clinically relevant. Depression versus bipolar, I know we kind of talked about that. However, a new study last year came out that childbirth might be the catalyst that triggers depression flipping into a bipolar disorder. So that's really important to know. It becomes bipolar disorder after birth. Psychosis. This is the really rare, about 4% of women will experience a postpartum psychotic event. It's rare for it to happen during pregnancy, but it can. More common in the postpartum period, most common within the first 3 to 4 weeks, quite common in the first few weeks postpartum because of that precipitous hormonal change. Now, I do want to say if a woman is having a postpartum psychotic event, it is always because she either has schizophrenia or underlying bipolar type 1. It is not, even though we call it postpartum psychosis, it's actually not a separate disorder. It's one of these two. And so then it needs to be treated. If she's actively psychotic, that is a trip to the ER, get her evaluated. It doesn't automatically mean she's not safe with the baby. We always go to the Andrea Yates, oh my God, you're just going to commit infanticide. Yes, infanticide happens, but it's incredibly rare. Again, infanticide is about, of the people with psychosis, about maybe 4 to 5% of that might commit infanticide. So, what are the psychotic symptoms? Again, delusions, strange beliefs, really strange. Hallucinations, seeing or hearing or feeling, thinking there's bugs crawling on their skin, thinking, oh my gosh, this glass of water suddenly is leaping out at me. It can be really benign hallucinations. I had a mom several years ago who bipolar disorder, and she had postpartum psychosis where she truly believed she was Shania Twain, and we had to have her watch 24/7 because she was a flight risk. She was about to go on tour and she didn't believe she had a baby. So again, it doesn't have to be dangerous, but we do have to get this mitigated. Let's see, hypervigilance versus paranoia. A lot of moms become hypervigilant, and there's this normal, like we want to check them breathing kind of thing. And then there's the hypervigilant where they can't go to sleep. There's a difference between, in the beginning, all the, because newborns, as we all know, are grunty, snorty, loud little things. But the moms with the hypervigilance cannot sleep at all. Every single peep. These are the people that maybe wanted to go sleep and they can't, because it's like every little sound is just keeping them up, every little rustling. Paranoia is when maybe you're starting to think, oh, but an intruder might come in the house. I have to check all of the windows 5 times and make sure that they're locked. Honey, we need to get a security system now because somebody will be coming to take my baby. I can't let you diaper my baby because something might happen. Now, I will say sexual abuse survivors have a hard time letting people diaper their baby or bathe their baby, etc. They have a good reason for being the way they are. Excessive hyperhearing. Okay, so as you probably all know that all women's biology, just like in pregnancy, our sense of smell goes crazy. Postpartum, our sense of hearing goes up, which is why we're pissed off at our partners, because we're truly hearing a lot, more than they are. And we're like, why aren't you waking up? The baby's crying. Okay. But the hearing is extra acute in moms with an anxiety disorder, actually, with that hypervigilance. And it doesn't turn off after a few months. We kind of like get a little, used to the baby rustling and stuff. And we learn to kind of sleep through certain things. Women with maybe an anxiety disorder, that hypervigilance, the hearing doesn't turn off as far as calming down. Paranoia, again, believing that people are lying against me, that they're plotting to take the baby from me. They're hiding things. You guys are talking behind my back. You guys were in the kitchen. What were you talking about? My baby hates me. This is a really common one that a lot of women don't talk about because they fear that everyone's going to think that they're a bad mom. So again, normalizing, hey, some of these kind of things come up. I just want to normalize these can be symptoms of a mood disorder. Are you experiencing any of that? That doesn't mean that you're a bad mom. Do I only have 10 minutes? Oh, 30, thank you. My eyesight, I'm getting old. Again, so I'm going to just burn through some of these because I want to, infanticide rates, because I want to get through a lot of this. With psychosis, most women do not harm themselves or others, like I was saying. Mother-baby safety concerns. Women are usually quite tolerate well, saying, hey, we need to get a safety system around you. We're going to need to get family, neighbors, doulas, etc. And if they don't have that, maybe that is a good reason to be in the hospital too, just because they don't have that system to help provide the support that they need while they're of high risk. So we kind of talked about that. Sleep and psychosis. One thing to rule out, she might not be bipolar or schizophrenic, but she is having psychotic features because of severe sleep deprivation. This is why sleep deprivation is a torture technique. We hallucinate if we're not getting good REM cycle sleep. So this again is when I'm doing clinical interviewing, I'm finding one of my top things in that first appointment is, what does your sleep literally look like? Is the baby getting up every hour? Are you not be able to sleep when you get to sleep? How long are you sleeping? A REM cycle takes a minimum of 3 hours to happen, that rapid eye movement sleep, and we replenish our serotonin, our neurotransmitters during our REM sleep. So that's why the brain, if we're super serotonin deprived, we become psychotic. Again, so that doesn't necessarily mean she's having a bipolar or a schizophrenic episode. It means she needs sleep. So sometimes that's a number one intervention to do. And I talk about, maybe you do need to pump and let somebody, I am Ms. Breastfeeding, but yet if she is having psychosis because of sleep deprivation and she cannot pump, this might be a time that, hey, formula has a time and place. Let's have a happy, healthy mom that maybe just needs this for a week or two, and then you can go back to full-time breastfeeding just for that, just so she can get a chunk of REM sleep consistently. OCD, again, about 9% of moms. This can be misdiagnosed as psychosis because some of the obsessive intrusive thoughts in some women have a very scary, nightmare-y type quality. Mary Jo Cody was the first lady of New Jersey about a decade ago, and she was really good about talking about this. She had postpartum OCD, and she had intrusive thoughts of putting her baby in the microwave that she could not stop. but she wasn't psychotic. The thing with OCD is that they know these are wrong and they're horrified by these thoughts. Psychosis, it makes perfect sense in the world to them. That is like the reality that they're experiencing. OCD and the intrusive thoughts of the scary nature, they know that they're wrong, and these moms are not at risk for hurting their baby. But sometimes the clinicians, we overreact because we don't know, because we're not taught this kind of stuff when we go to school very well. So normalizing when I'm doing an interview, just again saying, hey, I just want to say some of these symptoms, they can be pretty scary thoughts, but they're horrifying to you. Do you ever have things like thoughts of something happening to your baby? I just say generalized terms because I don't want to, plant thoughts or traumatize her with inserting a thought that then she can't get out of her brain. So I just say a generalized statement, and then if they start talking, and I often say, don't worry, this is part of the illness. I'm not calling CPS because you are clearly upset by this. That means you're a good mom. That means you know right from wrong, and I'm not worried about that because every mom is so afraid that we're going to call CPS is going to be called on them. They often have rituals to put away things that might hurt their baby because they're really worried about that. So I want to get into treatment. Again, PTSD, just real quickly, it's in the eye of the beholder. We might have what we consider a normal healthy birth, but because of the mom and other circumstances that we might not know about, it is a horribly traumatic experience for her. About 18% of women in a study of 2011 stated that they experienced a traumatic birth experience. Now, about 5 to 9% of these women go on to develop clinical levels of PTSD. So this is really important for us to know. What are the themes? What is leading to this? And the main themes are perception of lack of care and respect by providers. Excuse me. And I want to highlight perception, the perception. Feeling abandoned, feeling stripped of dignity, feeling a lack of support or assurance, feeling the lack of continuity of care with providers, which that doesn't happen with midwifery. Why I love that. Perceptions of poor communications. Again, a lot of this is perception. So it's really important to check in with the mom. The mom might feel invisible, not seen, heard, validated, feeling powerless and out of control. This is one of the number one themes I hear, that feeling that actions are done to her versus with her. Then they feel a betrayal of trust and they don't feel protected and safe. And then do the ends justify the means? They always hear, but your baby's happy and healthy, but look at your baby, versus what happened to me. I am important in this equation. Okay, so treatment, getting into that because I want to make sure that we covered the treatment. A good comprehensive approach includes therapy, possibly medications, sleep, diet, because we are what we eat in chemistry. Anti-inflammatory diet can be a very good thing because of the correlation between depression and inflammation. So things like going wheat and sugar-free, etc., the things that we know cause inflammation. Self-care, really defining what does that look like. And the PSI warm line goes through a really nice 9-point step of self-care and how they can add that in. So making sure that and the social supports, whether it's family, friends, social support groups like PSI's groups. I'm going to flip through some of these quickly, but the nurse program of self-care, nourishment, feeling understood. Are you getting enough rest? Do we need to do some intervention to help you get some sleep? Are you doing anything for your soul? Do you have eye candy to look at? Pretty glass in the window? Just something that makes you feel good. And exercise, that constitutional little walk with the pram that they do in England, like getting out. And light therapy, actually, even on a Pacific Northwest rainy day, you get the full spectrum light. And I actually prescribe that for moms. Actually, there's been some research that I didn't cite in these slides, that light therapy, not for same kind of light therapy that you use with seasonal affective disorder, but regardless of seasonal affective disorder, light therapy helps with postpartum depression in particular. And you can get full spectrum light just by going for a walk without sunglasses, because you don't want the polarized lenses to mitigate that therapeutic effect, and about a 30-minute exposure. Mental health assessment for you guys, this is something you can do. Your symptoms, your stressors, do you have adequate support? What does your sleep, what are your eating look like? What are your health and habits? Do you have an abuse history? Do you have a substance abuse history? Is there any domestic violence going on? We do know, just briefly, domestic violence, if that is existing in the rate, you guys probably know this, but it goes, you're more likely to have an increase of domestic violence during pregnancy than have it go away. So universally, the best standards practice that I hope that you guys can start to implement, if you're not already, is providing pamphlets, literatures. PSI will provide free as many brochures as you need to hand out to your moms. And we recommend giving them at about the 20-week appointment, so you're catching those onset during pregnancy moms. Again, about a month-ish before birth, around 36 weeks. And you can also be giving them the Edinburgh, which is a self-assessment screening tool. And I have some links in here where you can download them online. And it's available in multiple languages. And again, at your 2-week checkup and at your final postpartum visit, and letting them know, again, this can onset later on during the postpartum year. Normalizing this, letting them know that this is the number one complication of a pregnancy, letting their partners know, please look out for this, letting their partners know you can experience this too, that 10% of dads do, and PSI is there for them too. Addressing the stigma, because that's a barrier for care, letting them know this is a biochemical response. This is a medical issue. It is not your fault. Different kinds of therapy. Again, there's a lot of different approaches. One of the things that I work with too is birth trauma. There's a different kind of approach that you do with trauma than you do with other kind of approaches. So you guys don't really, I just wanted you to know some of the treatment approaches with therapy. Medication management, I'm going to go more into this because just so that you guys know, you're going to be seeing women in your practice. Maybe they're on these meds. How does this affect them? And they're most afraid of, how is this affecting my baby? I just want to do a disclaimer. I'm not a prescriber. I'm providing you information that is out there in the literature and just the best practices that I have seen working in this field for many, many years. So here's some good websites that I hope you all know and have ready on your little speed dial on your phone, and some of these even have apps on your phone. The Lactin, as you guys know, LactNet and stuff is an app on your phone, but these are good resources about meds during pregnancy. Okay, so should women who are pregnant take meds or not? So many people are afraid of this, and you're right. There's no such thing as no exposure, but we know that stopping the meds in some cases can actually be potentially worse for the mom and the baby than staying on the meds. So it's a clinical conundrum. There's no such thing as no exposure, and I drill this into my moms because they think about informed consent. They think about just talking about the exposure to the medication. But I also talk in full informed consent is exposure to the illness untreated. And we're seeing, especially in the SSRI treatments, that actually the babies, the fetal development, the birth outcomes, and postpartum follow-up, these children are actually doing worse if they're exposed to an untreated illness than to the SSRIs. And there's a lot of data out there now. So antidepressants. I have combed through, and there's some really good meta analysis out there now that have been looking at a decade and more of research. So I brought the latest of the latest, 2013 Current Psychiatry, antidepressants during pregnancy. The conclusion is the overall risks are low, and the fear of lawsuits. This is, I don't know how it is in the midwifery community, but the OBs are like terrified of lawsuits, and so they often err on the, well, I don't want to give you something. But again, they're not looking at the detriment is actually potentially increased exposed to an untreated illness. So med management during pregnancy, realizing the dosages of what worked for, say she was on something, Zoloft, Paxil, Cymbalta, something prior to pregnancy. Pregnancy, as you guys know, her maternal blood serum goes up, her metabolism goes up, etc. She needs to be working closely with a psychiatric provider that specializes with this, because her dosage needs are going to radically change during pregnancy. And again, once the baby is born, her dosage needs are going to change postpartum, because suddenly her body is different. So med discontinuation, as I said, taper. If she is going to go off, if she does want to go off, mitigate the discontinuation syndrome, flu-like symptoms, nausea, sensory and the suicidality thoughts, the intrusive thoughts go way up if she goes cold turkey. In the neonate upon birth, when the baby comes off, the one and only thing that we're really seeing as far as, because they're like, what is this going to, do? What's the worst that's going to happen to my baby? Pretty much we see a fussy baby for a little bit. And this is like the max, up to 2 weeks. I have never seen a fussy baby longer than 4 or 5 days. That's just in my clinical experience. And we're not seeing long-term effects. We are seeing and documenting long-term effects of children exposed to untreated illness. We are not seeing, it's not been documented, long-term effects of the children who have been exposed. So I have some slides, and basically you can download these online, and I just cover one of them that are good cheat sheets for you guys. Cheat sheets, download them. The meds, it talks about, oh my God, I can't read. Anyway, it talks about fetal neonatal risks, exposure, half-lives, etc. Good cheat sheets. Download, the links are on there. I can email that to you. ACOG just came out with a joint, not just, it's 2009, acknowledging that there's an increased risk with antidepressants of earlier delivery. Again, these are slight risks. The stat numbers are actually, I apologize that I don't have that. I'll have to pull that up, or you guys can look on that report. But an increased risk of some preterm delivery. However, in bold, the majority of studies that evaluated antidepressant risks were unable to control for the possible effects of a depressive disorder. Across the board, we see if a woman is having postpartum depression and anxiety, I've got 15 minutes, she is at increased risk for preterm delivery, low birth weight babies. The babies sometimes are fussier, neuroendocrine abnormalities. Babies can have cognitive deficits, and later on increased risk for their own mood disorders and mental health. And so it's hard to say, chicken and the egg. Are they having preterm delivery, in this case, tracking that because of a medication or because of the illness? And they readily, in the article, admit that we're having a hard time to control for that. PTSD therapy, there is both therapy parts, but there are medications used. Prazosin blocks the release of adrenaline and reduces nightmares. We give this a lot with women with intrusive nightmares. Ceromycin boosts the activities of NMDA, which is needed for fear extinction. Propranolol is a very common one. It's a beta blocker. It's used in it's a cardiology originally medicine, but it also can interrupt memory to inhibit flashbacks. So in my clinical experience, I have yet to ever work with a bipolar or schizophrenia, any kind of cycling, that mood disorder spectrum, that wasn't able to be managed without adding meds in. It is just such a strong biochemical issue. Excuse me. Let me get a drink. Whereas SSRIs are now just kind of leaving moms on them if they're already on them during the first trimester and the whole pregnancy. Bipolar meds are different. Mood stabilizing meds are different. A lot of them are teratogenic during the first trimester. However, they are somewhat safer, nothing is perfectly safe, but somewhat safer in the second and third trimester. So a lot of moms with an existing bipolar or schizophrenic disorder do choose to go off their meds for the first trimester until all the neural tube and organs and stuff are formed. And so it is really important, hopefully, to do some prenatal care. Sadly, some women, if they find out they're pregnant, like how many of us find out we're pregnant like 8 weeks in or something? By then, if they've already still been on mood stabilizers, they've already been exposed, the baby's already been exposed, and most of the things are already formed at that point that we're going to be affected by the meds. So again, then it's a choice that she should do closely with her psychiatric healthcare provider about whether to stay or go off her meds. There's different kinds of meds just to familiarize yourselves when working with a cycling disorder or schizophrenia. There's mood stabilizers. Lithium, antipsychotics are mood stabilizers. And then there's the anticonvulsant family. And there's actually a lot of research on women with seizure disorders that need to stay on their meds during pregnancy. We do know, for example, Depakote, valproic acid, causes, encephalitis and all sorts of really bad neural tube defects. So we do want them to go off that prenatally for the first trimester for sure. However, some of them we're clinically seeing Seroquel, Lamictal, Motrigine, of women staying on that throughout the whole pregnancy, or sometimes switching over to one of those if they've been on one of the other ones that is not so safe. These are often used in combination with an antidepressant only after the mood stabilizer has settled the cycling part of the issue, and that there's pervasive depression. Then we often do polytherapy with meds and add in a antidepressant, but the antidepressant can destabilize them if they don't first have a good mood stabilizer on hand. So looking at, again, antidepressant safety during pregnancy, recent data shows there is not an increased risk in the general population on organ-specific defects. So there's this background rate of 2 to 3% in the general population that is already going to happen. And so they're documenting the same background rate when on SSRIs and antidepressants. There's a really nice study that came out last year looking at, it was Finland, Norway, Sweden, and Denmark. And look at this N number, almost 37,000 women they summarized, and they found no substantial increase in the overall prevalence of birth defects of infants exposed to Effexor in the study. And Effexor had been thought of as a little more iffy than things like Zoloft, et cetera. So really across the board, we're just keeping moms on it. Oh, I'm sorry, that was a 2015. Really, that just came out this spring. And then the 2014 one was looking at over 64,000 women. Again, in this one, no substantial increase of cardiac malformations. How many of you heard about that whole Paxil scare many years? Yeah, exactly. Right, exactly. There's all of these, litigation things. If your child was exposed to Anyway, that study was actually debunked. It was never being able to replicate, and they actually admitted that the rates in that were the same as the background rates. Again, the background rates that already exist of cardiac malformations. So just FYI, that whole Paxil scare has been debunked, and a lot of studies have been showing, again, no increased rates of malformations. However, allergies this season have been bad. There was a new study, and again, it hasn't been replicated yet, but I just want to give you all the stuff because moms come in and are like, oh my God, I read this. Now, there was something in where they looked at antidepressants and a correlation with autism. However, they weren't able to pin down, is this because of a mood disorder exposure or an antidepressant disorder? And they looked at both boys and girls in this study, and in boys only, there was a slight increase in susceptibility. I give you the citation of the study from pediatrics. But again, it was in boys only. I believe it was 4% rate, but they couldn't control. Again, they could not control. Is this because of a mood disorder? And so then we're saying boys born of moms with a mood disorder could be at an increased risk for autism as well, but not girls. Benzos, anxiety meds. Again, study shows that benzos do not carry a risk of teratogenetic risk. However, we do see with Valium, so this is a diazepam, benzo, different from Valium. Benzos are the Xanax, Klonopin, lorazepam. But we do see a bit of oral cleft palate issues with Valium. We do see if benzos are used during labor, because Xanax has the shortest half-life, 6-hour half-life. Klonopin has a 30-hour half-life. So if those are used during labor, we could have that floppy, sleepy baby that might actually have a hard time breastfeeding, etc. So we do see that as an impact on the baby. However, because their livers and stuff, they can't metabolize the drug as effectively as the mom, so they might be sedated. However, again, they will get over that as they can metabolize it out. And I'm running out of time, so more studies. Antipsychotic use during the first and second trimester for you guys to know clinically. 2015 study compared to women not on antipsychotics, there is a higher risk of gestational diabetes, hypertensive disorders, preterm birth, birth weight differences, venous thromboembolism. Antipsychotic, different from SSRIs, again, different from antidepressants. There are increased risk of major malformations, teratogenetic, increased risk of cardiac defects. This is not the Paxil stuff, but now we're talking about antipsychotics, typical and atypical, the things like Zyprexa and Seroquel and Abilify, etc. Lower birth weight, small for gestational age, preterm birth. So just things for you to clinically keep in mind. However, again, that bold at the point, association doesn't mean causation. It could be the illness. It could be the illness again causing some of this. Lithium, I'm just going to send you guys these slides. And so I just go through a lot of these just for you guys to have on reference. I'm running out of time. Future pregnancies, if you are working with somebody preconceptually, being able to work on this. An ounce of prevention, folate is critical when anyone's taking a med, an antipsychotic that has an increased risk for neural tube defects. However, remember, as you guys hopefully are getting on your radar, that MTHFR gene mutation, the methyltetrol hydrofolate reductase issue. And so women with this, it's a simple blood test. You can find out if they're homozygous or heterozygous for this gene. They can't process folate properly, which is important with pregnancy. So then they need kind of this pre-methylated folate version, like Deplin or something like that. So just making sure that you know, again, some information. Antidepressants during breastfeeding, across the board, the antidepressant family is being used. Some of the mood stabilizing meds are being used. Zyprexa is being used, Seroquel is being used, Depakote is being used. Do not let a mom on lithium breastfeed. do not, because lithium will cause liver toxicity. The babies just cannot metabolize that fast enough. So if she wants to breastfeed and she needs lithium, she's either going to need donor milk, or she's going to need to change her meds or formula feed. Lamictal being used with breastfeeding these days, actually. It is reassuring in lamotrigine. There's some good studies showing the doses that are used to treat kids with seizures is way higher than what they can get in the breast milk. So that's quite reassuring. Risperdal, limited studies, but again, they're using it with some relative safety. Good websites on meds and breastfeeding. The best approach is psychotherapy with medication management. If they need meds, never do meds alone. Always do it in combination with therapy. And when we can, social support, support groups, PSI. Here's sites to download the screening tools. The easiest one is the Edinburgh. It's a self-administered. If they're scoring 12 or higher, refer them out to a mental health evaluation. Here's good resources for moms if you're going to have, when you're doing that screening, giving her the Edinburgh, a PSI brochure, and maybe a printout sheet of good website resources for her. Whoa, what happened? Was I at the end? Oh my God, I don't know what happened. I think I was at the end. We'll call it good because I know I'm at time and I don't want to impair Christina. Any quick questions, you can always shoot me an email. I know I went because I wanted to disseminate a massive amount of information to make a big difference with you guys. Quick questions? Yes. Is this Amanda Val? Yeah. Thank you. All slides will be on the website. Yay. Any other questions? Yes. Ideally, minimum of 3 hours. She was asking, what's the chunk of sleep time to get REM sleep? Ideally, minimum of 3 hours. We'd love to see 3 to 5 hours undisturbed sleep. So that would probably mean somebody needs to take the baby for a feeding. And I actually say, take them to the opposite end of the house, take them for a walk outside, put, earplugs in, noise machine, so you don't hear that baby, so you can get a good chunk of sleep. Ideally, 1 is nice. Ideally, two in a 24-hour period. It doesn't have to be consecutive, but that could be basically as good as medication in some results for some moms. Other questions? Yes. Yes. Yes, it's been validated to use with anxiety disorders, the EPDS, the Edinburgh. Yeah. Same. Yep. Mm-hmm. Yeah. And if you're in, if they're like 10 or 11, you're still concerned, go ahead and just refer. It's just a screening tool. It's not diagnostic, just screening. Anyone else? All right. Thank you so much.
Thanks so much, Heidi. I'd like to introduce our next speaker, Christina Chamberlain. Christina is a certified nurse midwife, women's health nurse practitioner, and international board certified lactation consultant. She's the owner of Eastside Women's Health and Lactation, where she provides gynecological care, pelvic floor therapy, and breastfeeding medicine and lactation support to women in the Seattle area. She's also a member of the adjunct faculty of the Midwifery Department at Bastyr University. She recently published her first book, I Can Breastfeed, Visualizing Your Way to Breastfeeding Success. Please welcome Christina.
Oh, so you can't move the laptop. That's the secret. Okay, thank you. Oh, maybe not. Okay. Is that good? Okay. All right, great. So we're going to talk about PCOS, polycystic ovarian syndrome, and lactation, and how that can affect breastfeeding. So hopefully after today, you will have a sense of knowing how to be aware of somebody who might have PCOS. Even if you're not actually diagnosing, if you need to do a referral, you'll know based on her history, her physical exam, any of her clinical signs. We're also going to talk about how PCOS specifically can affect lactation and breastfeeding. I'll talk a little bit about some of the pharmaceutical and herbal treatments for low milk supply, and then how we as midwives can support these moms in their breastfeeding efforts. So starting off, what is PCOS? So it's actually an endocrine disorder, but even though it's an endocrine disorder, most women end up going to their women's health care providers for treatment. And that's because the most common symptoms with PCOS affect our reproductive system. We don't have periods, we're having trouble getting pregnant, those kinds of things. So if you're seeing women, you're going to see somebody with PCOS. We don't really know what causes PCOS, but we have found that there is a genetic predisposition. So often these women will have moms or sisters, first-degree relatives who also have PCOS or some cycle irregularities if it hasn't actually been diagnosed yet. It affects about 10% of the women in the US population. And even though I'm talking about all the problems it can cause with lactation, I just want to be clear, it's not a nail in the coffin. Just because somebody has PCOS doesn't necessarily mean she's going to have lactation issues or low supply issues, but it's definitely something that you want to have on your radar if that starts to present itself as a cause. So for those of you who like numbers, these are the stats. So most women with PCOS are going to have some cycle irregularities. These women can have unpredictable irregular cycles, 5 to 9 periods a year. I had a client a couple of weeks ago, excuse me, who was diagnosed with PCOS prior to her seeing me, and she hadn't had a period in 20 months. That's a long time. So definitely that's a big part of their history. More than 3/4 of the women will have hirsutism, so that's abnormal or male pattern hair growth. They'll have alopecia, which is balding, will have acne, and the majority of women with PCOS we find are overweight or even obese. So all of these symptoms are a direct result of a hormonal imbalance, which we'll talk about. When we're diagnosing somebody with PCOS, we use what's called the Rotterdam criteria. So women have to have 2 of the 3 of these in order to be diagnosed with that. And so the first one is going to be an androgen excess. So lab-wise, that'll look like really high testosterone, free and total testosterone. She'll have ovulatory dysfunction, so she's not ovulating regularly. And she'll have polycystic ovaries, which is seen on ultrasound. So even though the name of this syndrome is polycystic ovarian syndrome, there are many women who do not have polycystic ovaries. So it's a little bit misleading. But if she were to have polycystic ovaries, so the one on the left is a normal ovary. So we tend to have some cysts develop as the follicles develop, but only one will mature enough to actually release an egg, and there you have ovulation. With a polycystic ovary, she's going to have multiple follicles developing. None of them will mature. No egg is released. And so she's not ovulating and she's not having her period. Hirsutism is usually seen, this is a pretty extreme example because if you Google, that's what you'll find. But hirsutism is usually seen in kind of the beard area or maybe the sideburn area, but it can also be seen in the chest area, usually in the cleavage or underneath the navel or in the thigh area. So other symptoms of PCOS, as I mentioned, is usually overweight or obesity. These are women who have a history of miscarriages or they have infertility. It's difficult for them to get pregnant. They can often have mood disorders, so part of that can be from the actual hormonal imbalance. Other parts of that can be self-esteem issues based on, you know, obesity or hirsutism or those kinds of things that can affect their body image. We also find that these women have insulin resistance, so their blood sugar levels are not regulated, and we'll talk more about that. And there's an increase in the LH and the FSH ratio. So usually the LH is a 2-to-1, too high of LH, too low of FSH, which is causing some issues with the ovulation. And then these women are also at higher risk for hyperlipidemia, cardiovascular disease, type 2 diabetes, and gestational diabetes, which is what you'll probably see. So this is kind of the cycle of hormonal imbalance. I usually think of the endocrine system, I kind of think of it as dominoes. So when one falls just right, it affects the next one, which affects the next one. And that's how it should work. And so when one domino is a little off, then all the rest are affected and they're not working properly. So first off, you have this HPO, the hypothalamic pituitary ovarian axis imbalance, and that's what actually is causing the big muck up here. So you have this hyperactive production of androgens. So she's going to have a large amount of testosterone flowing, and that's going to throw off the LH and the FSH. If her LH is too high and her FSH is too low, she's not developing these follicles to ovulate. She's going to have a chronic elevation of estrogen, which leads to a chronic elevation of prolactin, a low level of progestin, and then her insulin's going to be off. And then we kind of keep it all going. So it's this cycle. So specifically how the hormone imbalance affects the symptoms that you'll see is the hirsutism, acne, and the alopecia. That is all caused by androgen excess. So the high testosterone levels that you might see if you're doing lab work, excuse me, is directly affecting these symptoms. Then all the others, the LH, the FSH, estrogen, and progesterone, those are throwing off her cycles so that she's either having irregular cycles or long periods of amenorrhea. She's having trouble getting pregnant or sustaining a pregnancy. And it's also the cause of, if you were to see polycystic ovaries on ultrasound, that's where that's coming from. And then the insulin resistance, what we see is a higher BMI, especially if women are over 30, then we're going to predict they're probably going to have some lactation issues, which we'll talk about in a minute. But these women tend to have the majority of their adipose tissue in the waist circumference, so larger waist ratio. And then the insulin resistance is also what gives them the higher risk of the cardiovascular and lipid issues. So recently, we have found that insulin does play a role in milk production. There have been some studies that have actually linked adolescent obesity to breast development issues. So when we see a woman today, pregnant or postpartum with PCOS, where things kind of went awry was actually years prior when she was hitting puberty and her breasts were developing. So it's not necessarily something in the pregnancy that went off, it's actually way before then. So what we have found, there's a preliminary study that, and I'll just say my plug here for any researchers, there needs to be a lot more research done on this topic, but there's a preliminary study that shows the breast tissue, the receptor sites actually need to be insulin sensitive for milk production, for the whole process to work correctly. So that's why if we see an issue with insulin resistance or hyperinsulinemia, it throws off the lactation. We have found that studies have shown that insulin does have a direct result for lactogenesis 1 and 2. Lactogenesis 1 is the production of colostrum. Lactogenesis 2 is when milk comes in. So for somebody who has blood sugar issues, probably is going to have some issue with her milk coming in or for her supply overall. So even though I'm talking about obesity and overweightness being a potential issue, I want to make it clear not every woman who is obese has milk issues, milk supply issues. Again, it's just something we want to keep track of and watch if that is the case. So when we talk about breast development, what's happening in puberty is that the mammary glandular tissue, the development of that is not happening the way it should. So here's some drawings. Type 1 is what we consider normal breast tissue. So her breasts are round, they're spaced close together, they're fairly the same size. She has a normal proportion from areola area to the breast tissue itself. When somebody has insufficient glandular tissue or hypoplasia, it means that the breast itself did not develop adequate glandular tissue. There's not enough mammary glands in the tissue itself to actually function appropriately in making milk. So types 2, 3, and 4 show different versions of hypoplasia. It's not the size of the breast that affects this. Small breasts can make tons of milk, big breasts can make not so much milk. So what you're looking at is the shape, the placement, and the asymmetry. Most of us have one breast that's a little bit larger than the other. So I'm not talking about, that's just a normal variation. What I'm talking about is a marked asymmetry. These women will have one breast that's probably a cup size or more bigger than the other. So you can see here, all three of these, the breasts are actually spaced wider apart. I kind of think of it as there's not really a lot of what we think of as cleavage for these women. And that's because, and they're also less round, more tubular shaped. And that's because there's just not a lot of mammary tissue to kind of fill out the breast itself. So looking at more real pictures, so you can see these women again, pretty wide spaced apart, kind of have more of that tubular shape to them, not necessarily what we think of as a round breast. The two on the left have a disproportionate areola to breast tissue ratio. You can see that the areola is disproportionately much larger than the breast tissue itself. So that's what you'll see when you do a breast exam. So what kind of information are we looking for from these women? So when we're taking a history, these are the people who are going to tell us they had a history of irregular cycles before they got pregnant. That's something I always ask people if I'm dealing with a low milk supply situation. I want to know what her cycles were prior to her pregnancies. These women might be overweight and obese, but really the information I'm looking for is that she's somebody who really has trouble losing weight, because that can be more telling of a blood sugar issue. If she's somebody who feels like she really is watching her diet, she's added some exercise into her lifestyle, but she just cannot lose weight, then I want to look more into that. That's kind of a pink flag I keep in the back of my head. So any infertility issues, these are women who either have a history of miscarriages or it took them a long time to get pregnant. That's usually what they tell me. They're able to get pregnant, so even if they didn't need reproductive technology to get pregnant, it just felt like it took a long time for them to do it. She'll say that she has always had acne, she's always had some facial hair maybe, something like that. She might know that she has blood sugar issues or she's had gestational diabetes in previous pregnancies. This is like awooga. If she tells me she hasn't had any breast changes in pregnancy, that's something I definitely take note of, because that's like a dark pink flag. And then if she has tried to breastfeed other babies before, what was that experience like? If she wasn't successful, really delve into why that was, and see if that gives you any clues. So when you're doing a physical exam, she's going to have a higher BMI most likely, not necessarily, but a higher BMI is going to be an indication of potential lactation issues. You're going to maybe see some acne or some male hair growth pattern. Acanthosis nigricans is a marker for prediabetes, and that's hyperpigmentation. Often we see that on the neck or the armpit area, under the breasts or the groin area. So if you see that, that's going to indicate that there's probably some blood sugar issues that you might want to investigate. And then I do strongly encourage you to do a breast exam in the beginning of the pregnancy. Even if you're not doing a full pelvic, I do encourage you to include a breast exam. I think that's a really great time, not only to see any of this stuff, but just to talk about what her breastfeeding goals are, what any breastfeeding education she might need, and that kind of thing. So, and then if you do see any of these things, it'll kind of change that dialogue so that you can have that throughout her pregnancy. But we kind of talked about what you're looking for. When you're doing a breast exam, you're looking visually at a lot of this stuff, but you're palpating the breast tissue. So I always tell people I don't have x-ray vision. I can't see your glandular tissue, but I'll tell you what I feel. And what I'm looking for is the lumpy bumpiness of breast tissue. I want to feel the texture of the breast tissue underneath, kind of like if I'm putting my fingers over my hands, I can feel kind of these peaks and valleys of breast tissue. If somebody has minimal or no glandular tissue, it's not going to have that texture. It's going to feel more smooth, kind of like my forearm. You know, if I feel my forearm, there's really nothing there. There's no texture to that tissue. So that is not what I want to feel. So if you're interested in drawing some labs, here's your slew of labs that you could do. If you were only going to pick one, I would do the testosterone, again, because that's going to give us a clue as to what her androgen levels are. I would do a total and a free testosterone. The rest can all, and these are all for non-pregnant people. For the glucose tolerance test, if you suspect that she might have PCOS, you might do that earlier in her pregnancy because because she's at higher risk for gestational diabetes, she might come up positive earlier. And then the thyroid panel is not necessarily related to PCOS, but your thyroid can affect milk production. So anytime I am working with somebody with low milk supply, I always do a thyroid panel just to rule that out. And then you probably don't need to do a pregnancy test when you see your people, but I threw in a pregnancy test because anytime somebody has amenorrhea, I just do that and rule it out. Yours will probably be positive. So as far as her breastfeeding scenario, when you're working with her, what is this going to look like in her breastfeeding relationship with her baby? These are women who often tell me, because The naturopath also gave her some liver and hormone support supplements. I don't know what they are. I'm not a naturopath, but that was what her treatment was. And then the last time I saw this woman, she had continued with the acupuncture, and she had gotten her period about 5 weeks after she started all of this, and she felt really excited about that. So that was about 6 weeks ago. So I'm curious to see kind of how she keeps cycling. So fingers crossed. So these treatment options, just to kind of give you an overview of what's available for women with PCOS who are not pregnant or not lactating. This would be what we do. And even if they're already pregnant or lactating, it's never too early or too late rather, for lifestyle changes. So the first line of treatment would definitely be diet and exercise, like for everything else, right? Diet and exercise. So definitely talking to her about a low glycemic diet, a low carbohydrate diet, because that's going to help regulate her blood sugar levels. Referring her to a nutritionist might be appropriate. I talk to women whenever I'm talking about diet about this whole low fat gimmick, because people think if you go on a diet, you have to decrease your fat. Actually, low fat foods tend to be higher in sugar, which is definitely not what she wants. So kind of teaching her how to read labels and understand what she's actually eating is important. Definitely stressing exercise, just moving her body at least 30 minutes every day. If she can incorporate some weight exercise there, that's going to actually be even more beneficial than just cardio exercising. There's one study that has shown that even a 5% weight loss can start to regulate women's cycles again. So just 5% weight loss can, boom, get her ovulating. So it's really, it really can be beneficial, but hard for people. So, finding out who her support, like if she needs a trainer, or if she needs to figure out how to go to a gym or a nutritionist, kind of getting her team together for that is important. Metformin is the drug most typically prescribed for PCOS. It's actually normally used for diabetes. It helps to regulate blood sugars and insulin sensitivity. There's some hint that it might also decrease testosterone levels. It can be taken in pregnancy. It's a category B. It does pass through breast milk, but it's for very low amounts, so it's considered safe to take when breastfeeding. It can cause some side effects though, like nausea, dizziness, and hypoglycemia, because if somebody, tends to crash with a little bit too much of that, it can make them feel a little woozy. In my experience, most of the women I see, just in my demographics, either don't want medication, so they choose not to go on metformin. Thank you. Or they have been on metformin in the past, and they've had these symptoms, and they didn't like the way they felt. So I haven't had a lot of experience in my clinical practice that people are on metformin, but definitely there are people out there, and that can help. There was a study done that kind of compared women who were using metformin and women on a placebo, just as far as how that would promote breastfeeding. Metformin itself does not increase prolactin levels, so it's not going to make women make more milk, but indirectly it's going to affect lactation and milk supply because of the other hormonal impact it has. So this study looked at moms, and they had half of them on placebo and half of them on the metformin. And then they did an interview 1 year postpartum to get their whole breastfeeding situation and what was occurring. And a lot of these women with what they suspected was PCOS or insufficient glandular tissue ended up stopping breastfeeding at about 3 months. And when they were asked why, they said that it was because they just didn't make milk. It wasn't because they were frustrated with all the things they had to do or that they didn't have enough support, which is important. And we'll talk about that in a minute. But this particular study was done in Norway, where breastfeeding is a very large part of the culture. It's seen as normal. Everybody does it. So these people probably did have a lot of support and still ended up not breastfeeding. So I just want to emphasize that, because a lot of times we say, oh, if you just try really hard, your body will make milk. And that's not always the case, especially for these women. But basically what the study confirmed was the takeaway is that metformin did not increase their breast size. So these are women who didn't have changes in pregnancy or postpartum, and the metformin didn't help with that. And these women didn't really have a full supply. So it actually hints more to the lack of breast changes and how that negatively affects milk supply. And metformin didn't help with that. So obviously this is for non-pregnant people. Oral contraceptive pills is sometimes used just to regulate cycles. Obviously there are other possible side effects, so it's not a great treatment for everybody. People can also choose to go on anti-androgens. The most common one we see is spironolactone. Spironolactone can cause feminization in males, so women who are on that have to be on birth control. So often that is prescribed with the pill at the same time. And that's a lot of education. She needs to know that she needs to stay on birth control if she's gonna use that. GnRH agonists can help with ovulation, and clomiphene, which is also known as Clomid, that can actually help induce ovulation. There's often that is used as an infertility drug as well. There's a slight increase of multiples with that one, but that can also be used. Obviously, none of these would be used by the postpartum mom. So again, I'm not a naturopath, I'm not an herbalist, so this is not my area of expertise at all. Some of you probably know more about this than I do, but when I was just doing my studying, these were the 3 supplements or herbs that came up often, so I was just gonna tell you about them and then you can do more research if that's something that you're interested in. But chromium tends to regulate insulin action, so it actually seems to be used a lot with blood sugar issues or with diabetes. The chasteberry can help with menstrual regularity. And then gymnema, am I saying that right? Maybe, okay. But that can also help with hypoglycemia and can help with weight loss. So what do we do with women who are actually breastfeeding? Enough about before that. So here's our second case study. Excuse me. This woman is 31 years old and she came to me with her first baby. She was diagnosed with PCOS when she was 16 and she took metformin for 2 years at that time and then stopped. She doesn't remember why she stopped. She claims she didn't have any adverse side effects. She doesn't remember it making her feel bad. She just stopped. She noted that her left breast did increase in size during her pregnancy, but her right breast did not. So one, she's having a lack of breast changes in pregnancy, and now we know she's got some asymmetry, right? She probably had some asymmetry before this, but now it's going to be more visually obvious that there's some asymmetry if only one changed in size or got bigger. When I did her breast exam, I did note that her breasts were wide spaced apart. She had minimal glandular tissue in all 4 quadrants, so I didn't really feel a lot of that lumpy bumpiness in breasts. She came to me when her baby was 9 days old. This was the first time I had met him. His birth weight was 7 pounds, 3 ounces, and it was a hospital birth, and he had had a frenotomy by a different provider in the hospital on day 3. So I saw them over 4 visits. So kind of looking at the whole arc of the breastfeeding pattern. So visit 1, when baby was 9 days old, she told me that she was breastfeeding him every 3 hours. And when I put here transfers milk, in the visit, I always do a pre and a post weight. So I weigh the baby before breastfeeding and then again after, just to get an idea of what baby's transferring. It's just a snapshot of the 24-hour period, but it gives me some sense of how babies are able to transfer, either what they're able to do or what mom has available to be transferred. So he transferred 12 milliliters. So at 9 days, not enough. She was pumping after each feeding and getting about 1/4 of an ounce. She noted she didn't have any changes in breasts. She didn't feel that they got bigger. She never felt engorgement or any of that stuff. So in the visit, I did check her thyroid just to make sure that that wasn't an added hormonal glitch. We talked about supplementing the baby more because he wasn't gaining adequately. I recommended craniosacral therapy for the baby because he had been tongue-tied. I recommend that pretty much for every tongue-tied baby I see. It just helps them be able to use what they got a little bit better now that they've been released. We talked about her adding some herbal galactagogues to her daily regimen. And then I recommended she either have the baby weighed by me or by the pediatrician in 3 days, but then to come back to me in a week so that we could still assess her milk supply. So I saw them then when baby was 2 weeks old. So he had a great weight gain, but he still wasn't at birth weight. So if you remember, his birth weight was 7'3". So he's almost there. But she's nursing around the same amount, but he's transferring much better, right? He pretty much doubled what he's able to transfer. So that's good. She's still pumping after each feed and getting the same amount, but baby's transferring more. So what baby gets, as long as there's not an issue with baby suckling or latch, then what baby transfers is a better indication of milk supply than what she can pump out. So that's encouraging news. She is supplementing with donor milk. She has access to a good supply. She feels like her breasts have gotten heavier, so that's good that she's seen some changes. We did talk about maybe using a hospital grade pump. That's just one of the tricks that we have. It's a different motor. I do see it make a difference for some people. Continue with the herbs. And then we talked about using a supplemental nursing system, an SNS, so that all of baby's suckling could be on her. Because right now she was using a bottle. And her thyroid was normal, by the way. So I saw them a couple of weeks later. She was nursing more frequently, but baby was transferring a little bit less. She had really decreased the amount that she was pumping, getting about 1/3 of an ounce. And she hadn't felt like her breasts had changed from the second visit to the third visit. So then we started to discuss, based on what I was feeling with her breast changes, the fact that she has PCOS. We talked about some pharmacologic treatments like the metformin, if she wanted to go back to her endocrinologist that she had known of when she was younger. And so she was going to kind of think about that. She wasn't really to commit to that treatment plan, but she was thinking about that. And so then we just talked about how to supplement and breastfeed at the same time and keeping up with baby's needs. The next time I saw them was at 7 weeks. So baby, look how much more baby's transferring. So 2 ounces, so that's kind of double. So that's a good sign. She's pumping really a lot less, because who wants to pump all the time? I don't find a lot of takers on that. So she's starting to pump less frequently, but she's getting more. So these are all really good signs that her milk supply is improving. She also feels like she can tell her milk supply is gaining. So at this point, you know, if she hasn't decided if she's going to do anything to specifically help with the PCOS, like metformin or any of that, and I've given her all the herbs and that kind of thing in my tool bag, then I talk about what are her goals now. Does she want to continue nursing and supplementing, and what that picture looks like, and kind of talking about that. I always praise moms for the work. I mean, she's been doing this for almost 2 months, right? Still maintaining. She was in really great spirits. Her baby really was open to latching on whenever she offered the breast, which is key, because if there isn't a lot of milk, sometimes the babies aren't as interested. And so that kind of throws the whole idea of partially breastfeeding off. But her baby was a willing candidate, and she was really happy to breastfeed whenever they wanted to, and she was okay supplementing because she had access to donor milk. So she was still considering seeing an endocrinologist or doing metformin or that kind of thing, but she wasn't quite there yet. So working with mamas postpartum. Prenatally, obviously we're going to get a really good history to see if this is even an issue. Checking if there are thyroid issues. If she has a history of breastfeeding issues because of a lack of supply, I would go ahead and just check her thyroid just to make sure that that's not an issue. And then obviously we can check it again postpartum. Her breast exam, we talked about that. What do you see in her breast exam? How can that impact breastfeeding and lactation? And then talking to her about starting now with her low glycemic diet and exercise. And then I always put nipples evert. That doesn't really pertain necessarily to PCOS, but everting nipples are always easier for babies than non-everting nipples. And then also you could consider, if you know an IBCLC who works with women with PCOS, who has experience with that, talking to her about seeing that lactation consultant prenatally so that they can come up with a game plan postpartum. So preparing for breastfeeding, I do have women start pumping when they're term. Obviously, I wouldn't do this beforehand, and I always tell my moms to go back to the midwives just to make sure that there's no contraindications to them doing this because, breast stimulation can cause uterine contractions. But I do recommend if she has an electric pump, just to use that 5 to 10 minutes a couple of times a day. Not to expect any milk. It's more of just stimulating breasts to get the breast tissue kind of ready for that. She's not going to actually make milk until the placenta is born. So I don't want her to freak out if she doesn't see anything, but that's something that can just help re-stimulate breast tissue. And then also just talking to her, who is her support going to be? Obviously lactation consultant, but just who is her support going to be after that baby is born? Then you guys know all of this. After baby's born, we do all the same things, immediate skin to skin, the first nursing within a couple of hours of birth. She's going to still stimulate her breasts 8 to 12 times in a 24-hour period, just like usual. This link here to Stanford University, if you haven't seen it, it's a really great video on manual expression. It does take place in a hospital. But most moms, I think, don't really know how to properly manually express milk. And so they think, oh, I can't really do that. I don't really get a lot. And then I get in there and I can get a whole spoonful. So if she watches this ahead of time, that'll just help her more adequately be able to express milk. And then I would recommend after feeding the baby for her to manually express and pump. It sounds like a lot, but the reason why she wants to do both is because manual expression will actually get more colostrum out. She can just manually express into a spoon and then feed that to her baby that way. But it's not doing as much to stimulate the breast tissue, and that's where an electric pump comes in. An electric pump is going to do a better job of stimulating the breast tissue, but it doesn't do a great job of getting colostrum out. She can pump and she won't get much. So until her milk comes in, I would recommend doing both as much as she can. So all lactation consultants have their favorite herbs. These are mine. They're definitely not the end all, but usually when I'm giving an herbal kind of prescription, these are the ones I go to. So fenugreek is really good, especially postpartum within that first month. It's going to have more oomph. I recommend about 1,500 milligrams 3 times a day, and that's best in a capsule form. Goat's rue, there is some studies or thoughts that it can actually help to produce more mammary tissue, to proliferate the mammary tissue. So if I'm suspecting insufficient glandular tissue, I definitely always recommend goat's rue. And that is best in a tincture form. And I recommend usually 2 milliliters twice a day, at least. And then malunggay leaves, this is the newest one that I've kind of discovered. You can buy it at any super supplements or anything like that. There is a company that bottles it nice and cute for lactation people called GoLacta. Their studies do support that it increases prolactin and makes milk. It's a plant found in the Philippines, and I've had Filipina clients who know it, use it postpartum. It's just a part of the cultural wisdom. But I always tell people that the studies from the company are by the company, so there is a little bit of that disclaimer. But anecdotally, I have more moms swear that that is what's helping their supply than anything else. So, and I again recommend 3 capsules 3 times a day, which goes to about 1,000 milligrams. All of these herbs actually coincidentally help regulate blood sugars. So one thing is, if somebody is hypoglycemic, you definitely want to caution to that if they're taking these, that they feel like they're starting to have low blood sugars, they need to back off. They should just have a low tolerance for that. But that just kind of backs up this idea of blood sugars or insulin imbalance affecting milk supply. And interestingly, goat's rue is the herbal precursor to metformin. So if people don't want to take metformin, that's another reason to take goat's rue. So these medications, domperidone and Reglan, I'm sure you guys all are familiar with them. They're not necessarily going to help with PCOS per se, but they are what we prescribe for milk supply. So domperidone, it's not FDA approved. Thank you. It's not FDA approved in the States, but it's getting harder to find somebody who prescribes it or a compounding pharmacy that will fill it. But the reason why most people prefer that is because it does not cross the blood-brain barrier, so it doesn't cause depression or anxiety like Reglan. Reglan can cause depression. Most of the women I see are already having some postpartum mood stuff going on, so I don't tend to prescribe it a lot. What I will say for both of these, though, is what they do is they increase prolactin levels. So they increase the hormone that makes milk, right? Well, the other side of that is you need receptor sites for those hormones to latch onto. And if a mom has insufficient glandular tissue, she doesn't have enough receptor sites. So it's like the lock and key system. You can give her a ton of keys, but if there are no locks to unlock, it doesn't really matter. So most moms come to me and they Google all of this and they want these drugs, and I explain to them it's not the magic bullet that they're looking for because of their particular cause of low milk supply. So metformin doesn't necessarily increase prolactin levels, but because it can help stabilize the hormonal imbalance, it can indirectly help with potential milk supply issues. Yeah. The metformin. Well, clinically, I don't have a lot of takers on it, so I don't have a lot of experience clinically metformin. I'm mostly going on research and what I've read and learned. Like that one study that I just referred to, it says that if there's insufficient glandular tissue, it's not necessarily going to help, but it doesn't say that there's all these other things being done too. So I suspect that if you're doing all this other stuff to support milk supply, like the herbal galactagogues, the pumping, good lactation help, that kind of thing, and you add the metformin, I do think it probably would help. Mm-hmm. So our last case, so this woman was 36 years old. She came to me again with her first baby. She had a history of irregular cycles, acne, facial hair, and she was also diagnosed with PCOS previous to her pregnancy. And she never took medication. She changed her diet and increased her exercise, and she started regulating her cycles. So yay, that worked. When she came to me, she reported she did not have any breast changes in her pregnancy. Her breast exam today showed that there was, upon palpation, a lack of glandular tissue. Even though her breasts looked normal, they were spaced close together. They weren't necessarily tubular shaped. They just didn't feel like there was a lot in there. She was going to go back to work full time at 8 weeks. Always makes me sad, but that was always known to be her plan. And so anything that we talked about breastfeeding wise, that was a big piece of what we were going to decide on. I saw them when the baby was 3.5 weeks old. That was the first time I saw them, and the baby still wasn't at birth weight yet. So this baby, I diagnosed this baby with a type 3 tongue tie and recommended a frenotomy, but the parents didn't do it then. They were going to think about it. So I didn't realize, I just picked these two case studies, these postpartum case studies, because I saw them recently, so they were fresh in my memory. And only when I was putting this together did I realize, both of their babies were tongue tied. Coincidence? I don't know. Go research that, somebody, and tell us. So this baby obviously had trouble latching on. And that was one of the things before I told the mom I thought the baby was tongue tied, that she said she couldn't latch on. She would come on, come off, come on, come off. And that's pretty much a classic tongue tie thing. Coincidentally, I also saw them for 4 visits. I don't kick people out of my practice at 4 visits. It's just a coincidence that both of these people I saw 4 times. So the first visit, the baby was 3.5 weeks old, and this baby was transferring about 1 ounce. Again, not quite enough. And she was not pumping very often and getting about 1/4 ounce each time. She was supplementing even before I met them. And she said that she didn't have any engorgement or any breast changes. So we talked about the frenotomy, and that's a really important piece, that even though you suspect PCOS or insufficient glandular tissue with mom, you always want to look at baby and how is baby contributing to the breastfeeding relationship. Baby is 50% of this. So if the baby is tongue-tied or anything like that, not for whatever reason, not able to latch on really well, that needs to be addressed just as much as mom's issues. So we talked about that. We went over some herbal galactagogues, her pumping, all of that stuff. And then I saw them again in a few days because parents decided to do the frenotomy. So baby transferred not much more after the frenotomy, but the first feeding after the frenotomy is not always fabulous. She was pumping more often and she was getting a lot more milk. So that was good. And I suspect now that we released the tongue tie, hopefully the baby could actually transfer that much rather than her just getting it from pumping. So she was going to do cranial sacral therapy, the tongue exercises that I usually recommend after breastfeeding, after the frenotomy, and then she was going to come back and see me for a follow-up. So I saw them almost a week later. So now look, after the frenotomy, this baby's transferring over 2 ounces, almost 2.5 ounces. So that's good. She is pumping a lot less again, but still getting the same amount each time she does pump. Before she felt like her breasts were a little bit fuller, but no change since that second visit. So I just talked to her about, because she can get milk out, that I was really hopeful that we could eventually get a full supply if she stimulated her breasts more. Now that baby was going to be better at getting the milk out, if she added the pumping, I felt like she really was a good candidate to watching it all come together and improve. But I saw them at 7 weeks and she really wasn't pumping, and she really felt like when she went back to work, pumping wasn't going to be an option. So she was less motivated to pump now. She was really just trying to enjoy her time with her baby, which I totally get. So we spent a lot of that visit just talking about what going back to work would look like for her, because she was going to be supplementing continuously, but she wanted to keep up any breastfeeding she could do. So we talked about what that looks like for her. But I do feel like I don't want to say she could have tried harder, because I don't want to say that, but I felt like there was really a good potential. So if you see somebody like this, it might actually work out. So what can we do with these moms? So one, like I said, we want to rule out any issues baby might have. And then the main thing I really want to emphasize is finding out what mom's goals are and meeting her where she is. Does she really feel strongly about breastfeeding, or does she really feel strongly about giving baby her milk? That's not always the same thing. And so figuring out if she's not going to be able to breastfeed exclusively, what is more important to her, and then helping her figure out how to do that for a long term. How does she feel about using donor milk? Most of these moms really are not interested in using formula and are very heartbroken that that's going to be a continuous part of her breastfeeding or feeding her baby. So we talk about donor milk, what she needs to know about that, how she feels about it. Would she be willing to use a supplemental nursing system throughout her breastfeeding experience? Most people think that that's something you just use early on in postpartum just to help with baby getting over this hump. But I have known women who get the larger ones and they use it the whole time that they're breastfeeding their baby. I've seen women, they just kind of tuck it into their bra and it's always there ready to go. So even in public, if they're breastfeeding their baby, it's right there. And that works for them. So that's something that you could approach with her. And then I didn't put this on here, but the big thing, kind of piggybacking what Heidi was talking about, is this affecting her relationship with her baby? Because I feel like mom's sanity is priority number 1 and baby's nourishment is priority like 1.5. So we have ways of helping baby get the nourishment he or she needs, but it's really hard to make moms feel good if they don't. So I want to make sure that all of these efforts that I'm recommending to her are not in any way lessening her bonding or her relationship with her baby. And I have met moms who feel that way. When I read testimonials from women who have insufficient glandular tissue, PCOS or not, a lot of what they say is it was really frustrating to work with a lactation consultant or a midwife who just said, you need to pump more, you need to try harder, and all this, because they felt like it was trying to get blood from a turnip. It just wasn't going to happen, and it just added to their guilt, their mom guilt. So I would just encourage you to be really aware of that when we're giving our breastfeeding advice. How are we adding to that, or are we kind of relieving her of that? So obviously, if she needs to be referred to a counselor at any point in pregnancy, if this has caused some body issues, if she has a history of infertility or miscarriages, if that's affecting this current pregnancy, postpartum, certainly thinking of my breasts have failed, if she has any of those thoughts, maybe that would be a warranted referral, referring to, like I mentioned earlier, a nutritionist, a lactation consultant, an endocrinologist, kind of having all these people in your back pocket if she needs that. And just being realistic about her breastfeeding success. As I was mentioning earlier, I always have kind of a cautious optimism when I'm working with these moms. I kind of explain to them, this is what I see, this is what I feel when I'm doing an exam, this is what you're telling me and what that means to me as far as your breastfeeding goes, and this is what I'm gonna recommend to you, but I would love for your body to prove me wrong. So I think that we can certainly work on it, but I always want to kind of be realistic so that she is prepared if it's not going to work out, I guess. So cautious optimism. And that's it. Thank you for what you do. Yeah, question? Question?
I just wanted to add to this really great presentation where I learned a lot. That I have found that a lot of these moms have anxiety / guilt / bordering on depression and so forth, and they really feel a loss of control. That is, they have this plan and it's not working out. And I've had really good success in addition to these sorts of things, like putting them routinely on block feeding. Because it reestablishes a bit of sense of control, reduces anxiety, and increases milk supply. So I routinely do that, and I found that it really, really helps. And for those of you who may not know what block feeding is, it just is a plan for which restaurant you go to. You still feed the baby on demand as much as they want, but from midnight to 3, it's the left breast. 3 to 6 is the right breast, and from 6 to 9 is the left breast. You just make up a schedule like that. She can have it with her. She always knows which breast to go to. And what the advantages are is it allows the opposite breast time to fill. And when the baby goes to that, and heal if necessary, when the baby goes to that breast, they get an immediate hit of sugar, which gives them the energy to keep going, to get to that kind milk, which then stimulates the brain to make more milk in both breasts. And I found that addition to what you said is really, really helpful. It's easy, women like it, and they still feed on demand. But it's just what restaurant you go to.
I like that. Restaurant. Yeah. Is there another question? Do I have time for another question?
A couple, but because the one, I'm not looking, I know it's not. The tongue exercises that you recommend after Pranami. Is it because you think they form bad habits? I just thought it was like my son, had to touch on me too. So I don't think you had any bad habits. And so I just sort of wondered, if you get to it sooner, do you think it's less important? Or
it's not so much bad habits. She was asking why to recommend exercises after a frenotomy for tongue tie. It's not so much the baby has bad habits, but the tongue is actually embryonically developed at 4 weeks. So your baby has, a baby has had time to use their tongue for about 8 to 9 months. So, and it's not that they have bad habits, but there has been minimal muscular availability for tongue movements because it's been restricted. So now that you've released the tongue, I kind of think of it as baby PT. It's helping them learn to use their tongue, those muscles that they haven't been able to yet. And then a lot of times tongue-tied babies will compensate by having really tense jaws because they can't open wide because of that restriction, or really tense lips. And so it's teaching them to relax the accessory muscles that they don't need to use as much. Part of the other reason I recommend tongue exercises is one of them is to stretch that area where it was released, and that's allowing it to stay open as it heals. Your body, if you have a wound, your body wants to heal it by putting those two ends together, but that's the opposite of what we want. It kind of defeats the purpose of the frenotomy. So during the healing process, we're constantly stretching it out. So that's another reason for it. Thank you. Oh, yeah.
One quick question. Do you recommend the goat's fruit prenatally
Yeah, I mean, nothing necessarily says, there's not a lot of evidence that'll tell you if it's okay in pregnancy. But I have, for some women, if they're coming to me, they're close to term already. I have done that, recommended that just to kind of help give it a boost. Yeah, and if you've seen that clinically, for anything, I would just say wait until they're around 38 weeks. There's minimal effect on the baby if possible. Yeah. I don't know. I'm not in charge.
So I learned the IDCLC course that I took in school talked about you really don't get that supply up in the first 2 weeks. Pretty much screwed, and I wondered what your own opinion is that.
Well, it's definitely harder. I think the window of opportunity is 12 weeks, but with every week that passes, the window does close a little, but it kind of slams shut for sure by 12 weeks. So I wouldn't want to wait that long. It just takes longer, but I think that it can happen. I would say I would really like it to be up by 8 to 12 weeks at the very latest. And I think that that's possible, but it's a lot of stamina for mom, and I can't fault her if she doesn't want to get with the program, because that's a lot. But I would think that you have a little bit longer than 2 weeks. Yeah. Most of the women I have seen tend to be obese. So my sample size of non-obese women is not very big. So I'm going to guess, though, if there's an insulin issue, that they're probably going to have more issues with lactation. Yeah.
Okay, so now we're going to do a quick break, and I just wanted to remind people that maybe trickle in a little bit later. If you could please make sure that you fill out all the evaluation forms for each session, turn them in at the end, and within a couple of weeks, you'll get your certificate. We also have 2 lovely ladies walking around during break. We have 2 fantastic raffle baskets, so we encourage you to go up to the front, take a look at those. And also, we're going to have Kristen Eggleston come up real quick with a few words. Yes, please. All names go on evaluations. Yeah, thanks.
Hello, this is just a quick reminder. I'm the membership chair. Please come and introduce yourselves if I don't know you. And about your profiles. Okay. All right. No, that's a good idea too. I just want them to come and check their profile.
We can just add a. Where's her charger? Just put it right here. Perfect. Right here. We lost power over there. It just has to be really good. I know. And then we'll have, or do you guys do it safely? Make sure you profile it too. I haven't done it. Yeah, maybe we should ask her.
Yeah. She did, yeah. She did. Just gonna power up just in case. I know these projectors.
Are you okay if we have you on YouTube?
Oh yeah.
We're live streaming.
No problem.
You might get more pics than everybody else.
No pun intended.
Okay. And we're gonna dim the lights as soon as
Sure. Do you want me to wear a microphone? Do you want me to wear a microphone? Just use this one? Yeah, that's fine.
that means you're stuck here.
That's
Because
right.
you want to walk.
That's
Because we
right.
have the wireless.
No, I can do whatever you want. However you want me to do it, it's fine.
No, our cord is really expensive.
Oh, is it? Okay, that's all good.
Hello, please take your seats. We're 4 minutes past our session start time. No, I'm just making a quick little membership thing. Shh, everybody come sit down, please. I'm not going to introduce our speaker. I just wanted to make a very quick announcement about membership, which is I do a lot of stuff by hand, making sure the profiles that you guys have entered actually make it onto our website. We're hoping to change that in the future. But in the meantime, please come see me. Raise your hand if you need my email. I'll bring you a card. Or stop by and see me at the desk so I can walk you through what you need to do. Thank you. Well, I could go on, but what Val wants me to say is that if you are a first-year midwife, LM or CNM, please come see us because you get a free membership year. Thank you.
I just wanted to say one more thing, I'm sorry, about the CEUs. You need to have paid the extra $10 in order to get those certificates. So if you haven't for any reason, you can go up front and do that. And then, as I mentioned, we highly encourage you to put your names on them. It's just used for general feedback to MAWS and for the speakers. So don't worry that a lot of people are going to see them. Although hopefully everybody will have glowing reviews for everybody. And some people have asked, the drawing for both the raffle baskets will take place at the end of lunch.
So I would greatly appreciate if you all could find your seats. It is my tremendous pleasure to introduce Dr. Martin Walker, perinatologist at Eastside Maternal Fetal Medicine. It is a little inconceivable to me that many of you may not know him because he is integral to many of our practices. He and his practice partners are so very, very generous with us. Anyway, I'm excited to hear what he has to say, and we'll get right to it. Thanks. Thank you so much.
Well, thank you very much for inviting me. Of all the things I do and all the things I've ever talked about, this one seems to have garnered the most interest. I have no idea why. But anyway, here goes. Marijuana and pregnancy. Well, marijuana. Well, as I'm sure you're all familiar with marijuana, it's especially in Washington and Colorado, we're becoming experts in marijuana. And we're rapidly becoming experts on marijuana in pregnancy. There's not a lot of stuff out there, as I'll show you. What there is kind of interesting. And what's really interesting is how our families regard marijuana and pregnancies, the myths, the realities. And I'm going to go over some of it and let you know what there is out there so you can tell people the truth about it, which is perhaps not as scary as some people think, and perhaps a little bit more scary than some people think. But anyway, I'll let you know what it is. There are basically two types of marijuana that people are using in Washington and Colorado, sativa and indica, and blends of sativa and indica. Sativa is the more stimulative type of marijuana. Indica is the more depressive, relaxing type of marijuana. They're basically all, they're all bred from this one plant. They're all hybrids of one variety or another. There are multiple different, about 70 different compounds in any one leaf of cannabis, but there are 5 main cannabinoids found in marijuana plants. The one that we've all heard of is THC, and then there's the acidic form of THC, and then there's CBN, which is not really psychoactively very active, and then the CBD and the acidic form of CBD. And these have various different effects on the body. THC is the one that has the most psychoactive effect, and is the one that is written on the packet when you go to the recreational store, and it gives the percentage of THC. The mechanism of action, well, we actually make our own cannabinoids, and the reason we make them is because they work at synapses in our nerves, and they actually also work peripherally in the body, especially in immune cells. Bit of physiology, obviously. Nerve impulses travel along nerve cells and get to a synapse where they promote the release of neurotransmitters which cross the gap junction, hit a receptor, and transmit on to the next nerve cell. What endogenous cannabinoids do is they are released from the postsynaptic nerve cell and travel backwards and hit receptors on the presynaptic, and they potentiate the production of the neurotransmitter. So they are made in our bodies, especially in our brains, to potentiate the transmission of neurotransmitters across synapses in particular parts of the brain. And when we smoke or eat or consume marijuana, THC stimulates these receptors and does the same thing plus plus. There are two main forms of receptors, the CB1 receptor and the CB2 receptor. The CB1 receptor is primarily present in neurological tissue in the brain. The CB2 receptor is present mainly in the body, in immune thymus, thyroid, also in the pancreas. So again, CB1 receptors, mainly localized in the brain, hippocampus, cerebellum, cerebrum, on the presynaptic portion of nerve cells, and CB2 receptors in the periphery, immune cells, and in the placenta. And just another little graphic of the same thing. And the THC and other phytocannabinoids are very, very, very similar to our own endogenous cannabinoids that we produce ourselves. So there you go. The research in this area about our endogenous cannabinoids and their effects and why we produce them and where we produce them is still very much in its infancy. There is not a ton of research out there. Metabolism, well, when we consume it, if we smoke it, it goes from our lungs to our liver, where active metabolites are created and circulate through our cardiovascular system and our brain. Inactive metabolites are excreted in the urine. Very rapid peak of active metabolites in our blood if you smoke it within seconds, really, and then a very rapid drop-off of THC. Some of the lesser active metabolites of THC, though, are present for very many hours in blood. And in fact, it's a very lipophilic drug. It's going to be excreted in your urine for maybe 2 weeks after you smoke a joint, or eat a cookie, or however you consume it. So it's very, very rapid, but very prolonged as well for some of these metabolites. So if you're inhaling it, it's in your bloodstream within seconds, in your brain within minutes. Tissue half-life of about 7 days. Umbilical cord blood levels have been measured at time of birth, and they've been positive, about 3 to 6 times lower than maternal blood levels, but definitely positive. So the fetus receives a proportionately smaller dose than the mother, and neonatal urine tests are positive, as you would expect in a lipophilic drug. It's also bound to fats and proteins in breast milk, and neonatal exposure for breastfeeding mothers has been estimated, and there's, again, not a lot of research, to be about 1% of the mother's exposure to THC for lactating moms. So in terms of fetal implications, and we'll go over the actual real-life research on this, but the animal studies suggest that fetal THC levels are, when you're actually exposed to THC by smoking or eating or infusing into an animal, fetal levels of THC at the time of infusion are 10% lower than maternal levels. That means that the fetus is getting 90% of what the mom is getting at the time that the mom is getting it. So not an insignificant amount. And the other thing that's interesting in animals is that repeated doses leads to a gradual accumulation, because this is a drug that's lipophilic. So you inhale it or eat it, you store it in your fat, you have another joint 3 hours later, more is stored in your fat, and it's stored and it's kept there, so your levels will go up and up, and the same thing happens to the fetus. As much fat as there is in the fetus, they concentrate it. And there are receptors for cannabinoids in the fetus. CB1 receptors that are present in our brain are also present in the fetal brain during the embryological period. what they do in the fetus, we don't know, but they are present. So the potential concerns that have been raised about fetal or embryological exposure, or in general reproductive age exposure to marijuana in the research literature, really run the gamut. I won't address male fertility, but there are some researchers in male fertility who postulate that cannabis reduces sperm production and sperm motility. There is some evidence that there is decreased ovulation in response to cannabis use around the time of ovulation. There's certainly altered prolactin profile, FSH profile, LH profile. So in the breastfeeding literature, there was a little bit of discussion about whether breast milk production might be inhibited by the chronic high use of marijuana. The transport of the egg along the fallopian tube could potentially be altered by the use of cannabis. Placental blood flow. There's, again, discussion about growth restriction, premature delivery, decreased birth weight, and we'll go into the evidence for that. So, what is the real life? What are we seeing? This is a I can't see my slides here. This is from the Centers of Disease Control and Prevention. This was published in 2013. That looked at the percentage of high school students who had ever used marijuana, and this is women, and it's 40%. So our young people are using a lot of marijuana, and this is all across the United States, and this is perhaps a low number. This is just a few years ago. If we look at the prevalence in the pregnant population from similar data, this is the Substance Abuse and Mental Health Service Administration. This is published in, let's see, 2011 to 2012. The number of pregnant women who have used marijuana and hashish within the past month is 5%. And these are self-reported numbers, so this is probably an underestimate in this particular group. This is 115,000 pregnant women. And I've got data from this year that was just published this month that suggests that this is actually a significant underestimate, especially in Washington State and Colorado. Maybe we can swing this way and I can stand on the other side. There's more women using marijuana who are seeking and receiving substance abuse treatment in pregnancy as well. So this is published last year in the Journal of Addiction Medicine, shows increasing numbers of women who are receiving medical care for substance abuse, and increasing numbers of women each year who are reporting chronic marijuana use when they're being admitted for substance abuse as well. This is one of those slides that mirrors this obesity epidemic. This is a proportion of pregnant women reporting any marijuana use from 1992 to 2012. Blue and green being low numbers, red, brown, and sort of black being high numbers. And you can see back in 1992, not very many people, any marijuana use on the coasts, maybe 25 to 30% of pregnant women had reported any marijuana use. In the middle of the country, 30 to 35%. When we get to 2012, we're up to really over half the country. Pregnant women had reported any marijuana use, not necessarily in pregnancy, but pregnant women in general. So you can see this march is very progressive. What are the characteristics of women generally who are using marijuana? Well, this is somewhat old data, and I think this is going to be changing, but in the research literature, it tends to be women who also drink and also smoke cigarettes, and a lot of the research is sort of contaminated by this fact. And I think in the next 10 years or so, we're going to see a different population of pregnant women using marijuana who perhaps healthier overall and are using marijuana perhaps like they might go to Whole Foods rather than we're thinking of. But the older literature generally finds that these are women who are not taking prenatal vitamins, that are using other illicit drugs, that have a higher level of intimate partner violence, higher levels of unemployment. But women who just use marijuana in pregnancy and don't use other drugs, they find in the literature generally more excessive weight gain, more likely to be nulliparous, etc. So this is somewhat old data, but kind of interesting. What is the effect of legalization? Well, we're only just beginning to find this, but I don't think it's a great surprise that states that have legalized marijuana have a higher usage rate of marijuana, that home growth, which you see in Colorado rather than here, is correlated with a higher and heavier usage rates. It's generally seen as safe compared to alcohol and tobacco. And as the price falls, as it has significantly in Washington state, we can probably expect to see even greater usage. This is from a paper just released this month showing the map of legalization of marijuana in the United States. These are the states where it's legal for both recreation and medical use, and these are the states where it's legal medically, and I think it's not going to be another 10 years before this green is going to cover the vast majority of the country, and this dark green is going to start to spread as well. This is a paper that was actually just released this month, a national survey of drug use and health between 2007 and 2012, asking women of reproductive age about how much they use marijuana. Non-pregnant women in the past month, this is women between the ages, I think, of 15 and 44, about 8% within the last month have used marijuana. This is every state in the nation. This is not by state. In the past 12 months, about 6% have used marijuana. Now, the pregnant group, about 4% have used marijuana in the last month. In the past 12 months, about 7%. In the first trimester, 7% have used in the previous month, about 9% in the past 12 months. So you can see a significant proportion, approximately 10% of people are using marijuana within the last month in the first trimester. So more than 1 in 10 pregnant and non-pregnant women reported using marijuana in the past 12 months. Data from this month. A considerable percentage of women who use marijuana in the past year were daily users, and according to this paper, met abuse and or dependence criteria and were polysubstance users. Now, these criteria were, they were trying to quit. They felt it interfered with their lives. And this paper recommends comprehensive screening and treatment for the use of multiple substances and additional research, et cetera, et cetera. Now, these are recommendations that ACOG also has, that all women be screened for the use of drugs, really by asking them, do you use illicit drugs, do you use marijuana, do you use alcohol, et cetera. This is really kind of interesting, asking why would pregnant women use marijuana? This is from Colorado from last year, asking pregnant women why they were using marijuana. These were current users. The majority to cope with anxiety, depression, stress, a significant number to help with pain, about half of them for nausea and vomiting, not surprisingly. Recreation, a decent proportion. Other reason, about 14%. These are current users. And these numbers are fairly well reflected for ever users and past users as well. So that's why people use it. But, you know, there's an idea that it's good for nausea. And I think pretty much everybody out there knows that marijuana is a good treatment for nausea because of its use in cancer. But I was trawling through the literature, and this just came out again in the last month. And I'd never heard of this before. And I thought, none of you have probably ever heard of this before either. There's this thing called cannabinoid hyperemesis syndrome. It's pretty rare. There's like 3 case reports, but if you talk to a gastroenterologist, they probably know about this. And it's only seen in chronic marijuana users, and it's seen in pregnancy in chronic marijuana users. So if you have someone that's puking uncontrollably and you just can't get a handle on it with Zofran or with Phenergan or with your usual treatments for hyperemesis, and one of their presenting symptoms is they're always taking hot baths and hot showers, that's the only thing that seems to relieve their symptoms, ask them about marijuana use, because if they're a chronic, heavy marijuana user, this is a recognized syndrome. And the treatment is to stop taking marijuana, and it gets rid of it. They feel instantaneously, well, within a day, it gets better. This is a case report, you know, this woman presented with a Mallory Weiss tear. You know, she was throwing up blood. They couldn't understand what was going on. They tried everything. They called in GI, and GI said, oh, she's got cannabinoid hyperemesis syndrome. She stopped smoking marijuana. She got better. And unlike stopping cocaine or heroin, you know, you don't get withdrawal symptoms. So she was fine. She did well. So that's just something to think about. I'd never heard of it before, so I think it's kind of interesting. Another thing that's really interesting, this is from, I think, Hawaii. This was investigating people who were using marijuana in pregnancy, low-income women who were using marijuana in pregnancy, and about half of them said that it was cheaper than cigarettes. Marijuana for them was cheaper to get than cigarettes. The average amount that pregnant women were spending in Hawaii on marijuana was between $6 and $10 a day. I mean, that's not an insignificant amount, but it's probably cheaper than cigarettes. And then this is also another interesting, this is from that first one that showed the prevalence of pregnant women using marijuana that was just published this month. They were looking at attitudes towards marijuana use amongst pregnant women. And in terms of how difficult it was, difficulty in acquiring marijuana, fairly or very easy, about 92%. And this is not, again, Washington State or Colorado. This is across the country. This includes Texas, Oklahoma, Kansas, everywhere, 92%. And the perceived risk of marijuana use once a month, no risk or slight risk, you're talking about 80% of the population, pregnant, reproductive age women population. And when you ask that same question for every day, these numbers are not that different either. So our reproductive age population can get hold of it very easily. It's cheaper than cigarettes, and they perceive it as less risky than smoking, less risky than drinking alcohol. And actually, they're probably right on both of those counts, but it's not zero risk, and that's what we're going to talk about. So one of the things about marijuana that we are now realizing is that it is different to marijuana 5 years ago, 10 years ago, certainly 20 and 30 years ago. Between 1970 and the year 2000, there was a 6 to 7-fold increase in the potency of seized marijuana. And I think we can fairly easily say between 2000 and now, in Washington State, there's probably been another 10-fold increase in the potency of marijuana that's available to you and I just down the street. From 1993 to 2008, the mean concentration of THC rose from 3.4% to 8.8%. And if you go into a recreational marijuana store now and pick up a bag of any indica marijuana, it's probably got a potency of around 23 to 26% THC, printed on the bag. Consumption's also increased. People don't tend to smoke joints anymore. They're smoking blunts, which are more like cigars. They contain a lot of marijuana, or they smoke it in pipes, or they vaporize it, or they eat it. This is a graph from, I think it's Mississippi, just shows the potency of marijuana every year that was seized by the police. And this just keeps on going up. And, you know, there's no reason why it just can't keep on going up forever, really. I mean, there's no upper limit to this. And in terms of volume of sales, this is, where is this from? This is from, this is national. This is national volumes of sales. This is medical marijuana sales. This is estimated future sales, and this is estimated recreational sales in the light green. So you can see this is a multi-billion-dollar industry, and I hazard a guess that this is somewhat of an underestimate. This is also pretty fascinating. I was saying as I came in, this is kind of a neat topic to talk about because I can stay up to date really easily because I can just go on PubMed once every few months and read the 1 or 2 articles that have been published on pregnancy and marijuana, and I can feel as though I know all about it because really there's not a lot of research going on except out of Colorado and a little bit out of Washington State. This is a PubMed search on alcohol use in pregnancy, tobacco use in pregnancy, cocaine use in pregnancy, marijuana use in pregnancy. So there's not a ton of research. And the reason there's not a ton of research, because the federal government doesn't want us to do any research on this topic. There are, for us who are interested in this topic of what are the long-term effects on our moms and babies, 3 studies we can look to. These will never be done again. They're the best that we have, and they're not perfect. But I'm going to go through them with you. The 3 are, and you will hear about these, they're the OPPS, which is the Ottawa Prenatal Prospective Study, the Maternal Health Practice and Child Development Study, MHCPD, and the Generation R study. These are longitudinal studies of pregnant women who were identified as smoking marijuana, generally smoking marijuana rather than eating marijuana, who were pregnant, who were stratified according to how much they were using, and were then, and then the outcomes of their pregnancies, their infants, their children, and their teenagers were evaluated on a serial basis. Pretty useful kind of work. The OPPS study, as its name would imply, is Canadian. It was started in 1978, and because it's Canadian, it's generally a middle-class, low-risk Caucasian population. The MHCPD study was started a few years later, 1982. It's out of Pittsburgh, and it's basically a teaching hospital clinic population. So higher risk, mixed race population, lower socioeconomic class population. The Generation R study is the most recent study. It's still ongoing, and so there's no teenage data from that study. It was started in 2010. Because of that reason, the type of marijuana used is perhaps most relevant to what we're seeing today. It's a multi-ethnic study out of Rotterdam, and it also was the only study to use ultrasound because it's a more modern study. So the OPPS study, initiated in the 1970s, the sample as a low-risk European-American middle class, about 700 women, recruited mostly in the second trimester. They collected data on alcohol use, tobacco use, and cannabis use during pregnancy. And of the original cohort, 2 comparative groups were selected for follow-up. There were 140 with any use of cannabis or alcohol, or at least 60 milligrams of nicotine a day, and 50 with no substance use. So they were comparing cannabis smokers of cannabis, drinkers, and smokers of nicotine with people that didn't use anything. So, and they classified the cannabis use as obviously none, or mild to moderate, which was like 1 joint a day, or heavy, which was at least 1 or more joints a day. Kind of quaint, really, when you think about it. And they followed them up to 18 to 22 years of age. And they had, at the end of all of that, they ended up with about 50 kids who had been exposed by 18 to 22 years of age. So, difficult study to do. The other study, the Pittsburgh study, initiated in 1982, was a high-risk, as I said, low socioeconomic group, mixed ethnicity group, about half African-American, about 3/4 single. They started off with more women, about 1,400 women, in the 16th week of pregnancy, interviewed at an inner-city clinic in Pittsburgh. And they selected women who were using 2 or more joints per week for study. So again, all of these women are smoking, they're not eating, again, mainly because of the time they started this study. And then they selected an equal number of randomly selected women from the remainder as a comparison group. And they ended with about 560 women. And they classified cannabis use as heavy use, which was 1 or more joints per day. And they had quite a few women in the first trimester, and then kind of the numbers dropped off as they had second and third trimester. And then light to moderate use was, less than 1 joint a day, basically. And they followed them up to the offspring up to age 14, and they got up to about, they got about 80 of the heaviest first trimester exposed fetuses in that final cohort, which is pretty good. And then finally, this Generation R study was initiated in 2001, multi-ethnic, so Dutch, Surinamese, Turkish, Moroccan. It's out of Rotterdam. They enrolled 10,000 women, followed them up so far to age 6. That's what they've published. And they got 220 women who'd used cannabis in pregnancy. About 170 only in the first trimester, 44 throughout the pregnancy. So they considered daily use, heavy use, and weekly use to be moderate. And then they compared them to tobacco exposed and non-exposed. And again, this type of marijuana was the highest levels of THC, generally because it's in the 2000s. So as in all of these, whenever you're looking at this research, I kind of implied this earlier, the confounding issues are, whenever you're looking at inner city, drug-using population, especially in the 70s and 80s, you've got these issues of socioeconomic status, other drug use, quality of home environment, a heavy preponderance of one race over another. It's very rare that you just get cannabis use compared to nothing. Usually people are using tobacco, they're using alcohol. It's extremely common to get everything mixed together. So it's kind of a tough study to do. But let's just go through what all of these things seem to find. The first thing, teratogenicity. So basically, none of the studies found that there's any suggestion that marijuana is associated with any fetal abnormalities. There were some really, really early reports back in the 60s that suggested that marijuana might be related to anencephaly, but no reports since then have ever shown any association with anencephaly. There was a recent report, I think out of 2014, that showed higher THC levels in the cord blood of stillborn infants compared to non-stillborn infants in one, I think it was published in the Green Journal, but that's the only report that's ever shown that as well, and I'm not really going to discuss that because there were some problems with that paper, but I think I'll sort of lump that in with teratogenicity. There's no real association with stillbirth either. Now, growth is one that you'll see a lot. There's conflicting evidence about whether marijuana use is associated with smaller babies or bigger babies. So there's some data from a study looking at pregnancy termination in women that had taken marijuana. That was published in 2005. So pregnancy termination at 17 to 22 weeks. They found no association between marijuana use and head circumference or abdominal circumference measurements in terminated fetuses. So that's one study. The Generation R study that's actually used ultrasound did find reduced growth from the second trimester onwards on ultrasound, and it's dose related. So in the first trimester, about 156 grams average. In people that are using marijuana throughout the whole pregnancy, about, 3/4 of a pound difference in weight. So the heavier users, the ones that use marijuana throughout the whole pregnancy, tended to have slightly lighter babies. So that's a Generation R study using marijuana that's more equivalent to the strength of marijuana we're seeing today. The Ottawa study found no effect on weight. They did find a 5-day reduction in gestational age compared to non-users. The Pittsburgh study found an increase in birth weight. So, really inconsistent findings. But the Generation R study is the most recent study, and it used ultrasound. And it's with marijuana that is perhaps more equivalent to the marijuana that we're seeing now. So, I think we just say that the jury's out on that, but there's probably a minor effect on fetal growth, especially on heavier users with higher quantities of THC. Now, neonatal behavior, which I think is probably, and of course neurological development is probably what's more important. First of all, withdrawal has not really been reported. So neonatal withdrawal is not really an issue. The Ottawa study suggested increased startle and increased tremor in the first week of life. The Pittsburgh study suggested altered sleep patterns in the neonates. The Generation R study noted no effect on neonatal behavior. So no consistent patterns of neonatal effect, adverse effect. Infant behavior and development, again, we're kind of all over the place here. The Ottawa study didn't find any significant association between exposure to marijuana and 24-month development. There were some memory and verbal score differences in the most heavily exposed infants at 48 months. Interestingly, motor skills were more advanced in moderately exposed infants at 36 months. So again, a mixed bag there. The Pittsburgh study didn't find any relationship between exposure and motor or mental development at 19 months. In African American kids only, prenatal exposure related to lower scores in short-term memory, functioning, and verbal reasoning. The Generation R study, which again is probably the better study, didn't find any evidence of association at 18 months and 36 months between these scores and exposure. They did suggest girls only at 18 months had higher aggression and inattention scores. So again, every study finds something slightly different, but there's very little evidence for any negative effect on infant behavior and development. Now, what about childhood behavior and development? Well, both the OPPS and MHPCD both found worse scores on memory and verbal scores in childhood when measured through childhood. OPPS also found negative effect on attentiveness, and MHPCD found increased impulsivity. It's kind of hard to tease these out from the overall milieu of being brought up in that environment. But of course, they were comparing to another cohort of kids who were brought up in that environment but weren't exposed to marijuana. So take that for what it's worth. So they're the only studies that analyze beyond infancy because Generation R hasn't got to that point yet. They also found more symptoms of what they call externalizing behavior, so I guess acting out in 6 and 10-year-old, and more delinquency in the high-risk MHPCD group. So this is sort of an overview slide. And, if you have handouts, it's in your handouts. But it basically just says what I told you about all of these things. Just gives you a basic overview. So I think the take-home message is that the effects of prenatal exposure to cannabis is subtle. And it's not gross, like you're not going to have an abnormal child, you're not going to have a dead child, you're not going to have a withdrawing child. It's not like crack babies or anything like that. But there are receptors in the fetal brain, the embryological brain, and it would be naive to think that there's zero effect. But teasing the effect out from all of the other things that are influencing that child's development, neurodevelopment, is probably pretty tough. But it may well have some effect on verbal, memory, attentiveness, types of development later in life and childhood, especially if you're a heavy user. It seems unlikely that light use, like once a week or once a month or once a trimester, is going to have any measurable effect. But heavy use, someone's taking medical marijuana for some chronic pain and they're smoking 2 or 3 times a day, I think it's entirely plausible that it's going to have some effect. Now, whether that effect is going to be damaging in the long run, we don't really know, but it's going to have some effect almost certainly. I think that's a reasonable read of this literature. do we do about that? Well, you know, given that 10% of people are probably smoking weed when they come to us, and given that maybe that's an underestimate, and given that's probably going to go up, it's not unreasonable to ask people, are you smoking marijuana, if they don't volunteer it? Now, we're okay doing that, and I don't know how many of you are not from Washington State, but if you're all from Washington State, we're all okay with doing that. But, you know, elsewhere, it's not so easy. ACOG recommends that we screen everybody. We ask them, do you smoke, do you drink? Do you take any illegal drugs or legal drugs? And just talk about it. But you have to be a little careful if you live in another state, because there are 17 states that consider substance abuse during pregnancy to be child abuse. And there are 3 states that consider it grounds for involuntary commitment. This is a little chart of those. Here are we, down here. We consider there's a targeted program that we can use for people that are taking drugs. But these are all the states that consider substance abuse during pregnancy to be child abuse. There's a bunch of them. Yeah. And Minnesota considers it grounds for civil commitment, as does South Dakota and Wisconsin. Yeah. And you're required to report it in Alaska, Arizona, Indiana, and these things have consequences. And if you're a mandatory reporter, that could end up with one of your moms in jail. This is from Amarillo. Newborn twins on drugs at birth. Someone tested their urine, mom ended up in jail. So be careful. So I only have 15 minutes left. Lactation. We're all interested in lactation. We all want our mums to breastfeed. I was really excited when I did my literature search last night to brush up on this, to find lactation and marijuana use, a review in Press. And so I downloaded it and read it, and there was nothing in it. There was no new data in it. So there's really nothing there, except for what I've already told you. This is interesting, though. Because it's lipophilic, there is some data that marijuana can be excreted into breast milk, and it can be found in levels in breast milk, sometimes, if you're a chronic user, up to 8 times higher than in maternal blood. So it's concentrated in breast milk as well, because breast milk is super high in fat. And I told you as well that THC can inhibit prolactin. So if you have a mom who's having difficulty establishing breastfeeding, she's just not making a lot of milk, ask her, are you smoking a lot of weed? Because maybe may have something to do with it. And just ask her to cut back, and maybe she'll make more breast milk. Just as a point of interest, the American Academy of Pediatrics recommends against breastfeeding if you're smoking marijuana. So that's what they say. Another interesting fact, we might not all be equally susceptible to the effects of marijuana. There is evidence, and I'm not talking about the psychoactive effects, I'm talking about maybe the prenatal effects or the damaging effects of marijuana. There is evidence that, of course, we know that teenagers and young kids who smoke a lot of marijuana doesn't do them any good in the long term. We've all seen that. But there is evidence that there are some that are more badly affected than others. There are people with particular gene polymorphisms who seem to have a more damaging effect on their brain from chronic use than others. There's this neuropsychopharmacology journal who published this study looking at teenagers who have this specific gene polymorphisms in this catecholamine methyltransferase gene, who had particular depletions of the volume of their caudate nucleus if they were marijuana users, and if they didn't have the gene polymorphism, didn't have the depletion in this. So this is an interesting area of research as well. So we're not all made equal. Another thing that you need to know if you take your clients to hospital and they are chronic marijuana users is that marijuana affects how people respond to anesthetic. There are anesthetic implications. There's a biphasic effect on the autonomic nervous system of marijuana. Low to moderate exposure to THC, you have increased sympathetic activity, so you're a little more agitated. Heart rate's a little higher, increased cardiac output. Go a little higher on the THC, you have the opposite effect. The parasympathetic takes over. You become bradycardic, and hypotensive. You can also get changes in your EKG. You can get reversible ST segment and T-wave abnormalities and myocardial depression. You can get adverse interactions with propranolol and physostigmine as well. So people that are chronic users, you know, the medical marijuana users who are using a lot of it, the anesthesiologist needs to know about that. So, in summary, in terms of the prenatal exposure, the evidence is somewhat inconclusive about exactly what happens to babies that are exposed to marijuana in utero, but there are some subtle effects on attention, executive functions, and behavior, especially by the time these kids get to adolescence. And the increasing potency and increasing usage, I think, is going to need ongoing evaluation. I don't know who's going to be doing that in Washington or in Colorado, but I think it's important. And I think criminalization across the country and in the converse assumption of safety really complicates our job in terms of counseling. Just professional recommendations. This is from Colorado. The American College of Obstetricians and Gynecologists recommends that we screen. And by screening, that just means talking. It doesn't mean urine screening. And it means we, that we refer patients if we find that they need help, that we try our best to protect the physician-patient relationship. The American Society of Addiction Medicine really, again, suggests that we educate our clients about all drug use, that we screen, again, by talking to people, and that we educate people about these things, and that if people need to be admitted for substance abuse, pregnant women especially should get the priority. I'm not sure if have I run out of time? Yeah. I just have a couple of quick things to show you. This was just published about a couple of months ago. This is from Colorado. They're a little ahead of us, so they have a little bit more data than us. This was presented to the Colorado legislature because part of their legalization program involved a monitoring of health problems. And just for interest's sake, some of the data they've collected. This was, again, published in December of last year. They found that current users of marijuana, 35% had used marijuana during pregnancy. Current users, this is in Colorado. 13% had used when breastfeeding, 41% had used marijuana since their baby was born. So a lot of smokers. This is users in the past 12 months, users in the last month. A lot of people in the states next to Colorado kind of going up in usage as well. Okay, this I think is interesting. So one of the things they have found in Colorado, and we will find here, and this is something you must tell your patients who are using marijuana, is, this is, look at this little blue bar here. This is the number of kids between the ages of 0 and 8 who are a subject of calls to the Poison Control Center for marijuana overdoses. None, and then lots. Okay, so medical marijuana legalized, commercialized, retail marijuana legalized. So, I don't know whether you've been into one of these places in Colorado, but it's candy. It looks like candy, and if you leave it out, kids will get hold of it. Same thing here. Hospitalizations and emergency department visits, 2000, prior to the legalization of medical marijuana. Medical marijuana legalized. This is N is 1. Medical marijuana legalized. Retail marijuana. So these are emergency department visits and hospitalizations. This is for children up to 9 years of age. So, we're adults, we can do what we like. Kids, they'll put anything in their mouths. So if you are going to smoke marijuana or eat marijuana, at least put it in a jar and put it on a top shelf, or put it in a freezer or something like that, because, it's not good for kids. So thank you very much. So the question is, what do I think about CBD extract? For seizures and things like that. Yeah. Well, there's just no data on it. So they're less psychoactive. CBD is one of the cannabidials, and it's not as psychoactive as THC, but it's going to attack. It's going to attach to CB receptors, CB1 and CB2 receptors. There's no research specifically on that in pregnancy. All of the research, as you see, is probably what we would call now skunk weed. It's just crummy weed. So there's really no research on the good stuff that's being made now in Colorado and Washington State. I think it's going to be fascinating, but we have zero data. So it would be just opinion. Sorry. Yes.
So in my practice in Tacoma, since this has been legalized, I'm listening to you talk and I'm thinking some of the moms will come in labor at a birth center in Tacoma, and I'm listening to their babies as they arrive in labor, and I've had to transfer a fair number of them that now that I'm listening to you talk, they probably were stoned before they came here and were chronic users. Are you hearing really low heart tones with moms that are, they don't seem like they're stoned, but I'm like, oh my gosh, here we go.
Well, I think really, so the question is, what effect does chronic use have on the fetal heart? Yeah, that's a really interesting question. And again, I don't know of any research on that, but people that smoke marijuana all the time, they don't look stoned at all, really. Chronic users, they're just like you or I. I mean, they're habituated to it. The babies, fetuses aren't habituated to it. Yeah, and if they're smoking a lot of it, that parasympathetic tone is going to be way high. They're going to have lower fetal heart rates, almost certainly. I'm not aware of any studies that have looked at fetal heart rates in chronic marijuana users that have shown that. Be kind of a cool study to do. Yeah, maybe we should do one. Yeah. 5-minute marker is up. Yes.
Do you have any thoughts about charting marijuana use? I mean, I guess in Washington now it's legal, but obviously not federally. And I don't want to get someone in trouble necessarily, but I want to have accurate information from my midwifery partners at the very least in the hospital.
Right. Yeah. So the question is, do I have any concern about charting it? I personally don't, because as you say, it's legal. I'm not sure. Yeah, no, I don't have any problem with charting it. I can't think of any federal agency that would get a hold of the chart, would cause trouble for the mom or CPS or anything like that. So no, I don't have any concern about that. Yes.
So I have a client who postpartum had a psychotic episode, and when after she was treated, she did a bunch of research, and she was at a pot smoker, and she found some research. She said it made a connection between postpartum psychosis and the pot use. I'm wondering if you've seen that.
I haven't seen it. There've been a couple of reports since legalization of recreational marijuana of people taking way more than they should and having psychotic episodes. There was one in Denver of some guy that had never taken it before and ate like 3 chocolate bars and jumped out of a hotel window, had a psychotic break. So I think if you really are exposed to very high doses, but that was an acute episode. I'm not aware of. I mean, there have been, there's some literature in the teenage literature about an association between heavy cannabis use and schizophrenia, but I've always thought of that as being people self-medicating their anxiety rather than a cause and effect. So I'd be interested. I haven't seen anything about the postpartum but I always think of postpartum psychosis as part of an underlying psychotic illness rather than as a postpartum event. Specifically. So yes.
I feel like I'm hearing a lot of women that use marijuana, they tend to believe that vaporizing it is safer for them to use it while they're pregnant than smoking it. Is there any truth to that?
So the question is vaporizing it safer than smoking it? Well, yes and no. I mean, of course, smoking it, you're inhaling more carbon and other tarry chemicals that we know are bad for your lungs. Vaporizing it, though, you get much more THC. And so if you're worried about the neurotransmitters, then vaporizing it isn't any better for you. Of course, vaporizing it's much more economical. You get more bang for your buck out of your bud if you're vaporizing it than if you're smoking it. So it's cheaper, I guess. So yes, it's better for your lungs, but it's not better for your baby. But yeah, I think if you're gonna use it in general, vaporizing it or eating it is probably better than smoking it. Yes, but I don't think it's better for your pregnancy. Yeah. Yes. So the question is, are there any studies comparing edible versus tincture versus smoking? Well, all of the studies that I've shown you have been smoked marijuana. All the Ottawa study, the Pittsburgh study, etc. In terms of the short answer is like the good studies, no, there's really no good studies that will compare these in terms of the effect on the fetus or the embryo. And all the animal studies, of course, they're just injecting it because animals can't smoke it. So there's no real good studies there. But if you're looking at if you're trying to draw some comparisons, metabolism wise, active forms of it are metabolized in the liver, created in the liver. So if you're eating it, it's just a slightly slower onset of action, but you're otherwise getting the same drug. So you wouldn't really expect a much more different effect on the fetus if you're eating versus smoking or vaping or tincturing. I think one of the big differences in the tincture is it's much higher concentration of THC in a tincture. You can get 40% concentrations of THC in tincture. It varies obviously according to the tincture. Than you could get maybe by eating. Eating, you might only get a 10% THC in a brownie or something like that. So it's going to vary. But I think from a pharmacological point of view, your fetus is going to be seeing the same thing. So I don't think it's going to make that much difference. Maybe the peak is going to be a little difference, but for the fetus, it's going to be about the same. But it's an interesting idea, and I don't think the research has not been done. Research hasn't been done. Okay, thank you very much.
Before I announce the next speaker, I have a general announcement to make that there is still room in the NARM item writing workshop. It's June 11th to 12th, 2 days, 8:30 to 5 at Bastyr. They are giving you free CEUs, 14 free CEUs and lunch both days. So see Susie Myers in the back under the big Bastyr sign. I'd like to introduce our next two speakers, Tara Cardinal and Marnie Raylene. Tara Cardinal provides women's healthcare services across the lifespan in South Seattle at her independent practice, Radiance Women's Wellness. Since 2012, she's been a member of Training, Education, and Advocacy in Miscarriage Management, where she's a trainer and consultant for family practice residents in the medical program at UW. Marnie Raylene is currently a Bastyr midwifery student, very close to graduating. For her master's thesis, she has created a practice guideline for expectant management of early pregnancy loss. Please join me in welcoming Tara and Marnie.
Welcome to Midwifery Care for Early Pregnancy Loss, optimizing client-centered counseling and management. There are numerous individuals and organizations that we'd like to acknowledge who have supported this work locally and nationally. I'd specifically like to give a shout out to Dr. Sarah Prager, who is an incredible mentor of mine and has contributed to this slide set. And she also is a primary author on the ACOG bulletin that just came out on miscarriage management last month. So our objectives today of what we would like to have you come away with is an understanding about the three different classifications of early pregnancy loss, about 3 safe, effective, client-centered outpatient management options for early pregnancy loss, about the different rates of success depending on the type of pregnancy loss and the type of management option chosen, understanding of how counseling your clients on this and ensuring their ability to get access to these options can be empowering and support them emotionally, as well as increase your familiarity and understanding of Marnie's practice guideline. So the background of this presentation and miscarriage management as a whole essentially centers around the fact that to this day, the management options are dominated by expectant management, wait and see, or operating room management, which can be by a variety of methods, either dilation and sharp curettage or aspiration for uterine evacuation, and that is most frequently accompanied by general anesthesia. And lack of support folks and so forth. So the origins of this project, training, education, advocacy, and miscarriage management that I work with actually came out of Governor Gregoire realizing that the family medicine residents in Washington state were not learning any outpatient miscarriage management in their residency programs. So we started there, and since then, the understanding and awareness of the need across provider types became apparent, and so we have trained in federally qualified health centers and military sites and education institutions and so forth, bringing the awareness of these management options to all variety of women's healthcare providers. So the capacities and limitations to our presentation today is we're going to be glossing over a lot of background on early pregnancy loss, and we're going to really try to hone in on the management options as well as introducing Marnie's practice guidelines. And we know that you all have incredible wealth of experience and understanding, and we hope that whatever that is that we're able to add to it, strengthen, reinforce your foundation. Just briefly, a survey of the room. How many of you here manage miscarriage in any way, shape, or form? Okay, and how many of you manage miscarriage beyond expectant management? Okay, excellent, and that's great, thank you. So a review, implantation takes about 5 to 7 days after fertilization and 3 days to complete. So 10 days after fertilization, the trophoblast begins to invade what's the decidua now. And a week after that, we would expect the embryonic disc to form. If that disc does not form, we have what is called an embryonic pregnancy. So the gestational sac is forming, but there's no embryo. Historically, these have been called blighted ovums. Beta HCG is a wonderful diagnostic parameter of pregnancy, but as you can see from the graph, it's not very specific. We have a general idea of what beta HCG values are indicative of continuing pregnancies, ones that are going to be spontaneous losses, and then those that are in the ectopic realm. And 21% of ectopic pregnancies can have beta HCG patterns that mimic normal progressing pregnancies, and 8% that mimic spontaneous abortion and losses. So ultrasound assessment is another diagnostic tool that we have in early pregnancy to help us identify abnormal pregnancies. This here are 3 milestones that you would expect to see in the order you would expect to see them. So we have the gestational sac around 5 weeks. You see a nice round sac, often fundally placed off to one side of the uterus. And then shortly thereafter, a yolk sac is visualized there. And then by 6 weeks about, there should be a embryo with cardiac activity. Ectopic pregnancy, pregnancy is implanted anywhere outside of the uterus proper. The most dangerous forms of ectopic pregnancy, well, ruptured ectopic is a life-threatening emergency, but the harder ones to diagnose are the ones that are in the corona, in cesarean scars, or the cervix, because they can kind of look like they are in the uterus. Heterotopic ectopic pregnancies are more common with artificial reproductive technologies, and that's where you can actually see one pregnancy in the uterus and there's an ectopic somewhere else as well. But they can develop anywhere there's sufficient blood supply, and they can be managed expectantly if they're resolving with medication, methotrexate, if they are under a certain size, usually 3 centimeters, or operatively if they're larger than that or if they rupture. So the terminology, the medical terminology is spontaneous abortion. The medical community is moving toward early pregnancy loss. The literature, all of these terms are used, but there was a point in time not that long ago where they were egging to go for early pregnancy failure, trying to move away from the failure terminology with such things. We know that those we serve, miscarriage is the lay term, but in this presentation they all generally refer to the same thing, a pregnancy loss under 20 weeks of gestation. So the background is that early pregnancy loss is very common, affecting 8 to 20% of pregnancies, more or less, depending on the research. And those are the clinically recognized pregnancies. And then even more of the pregnancies that are maybe what would be called chemical pregnancies, because the pregnancy tests these days are so sensitive that they can detect a little bit of beta HCG that maybe there was an attempt at implantation and it failed. But so those are called a little bit more chemical pregnancies. So that adds up to about 800,000 to 1 million early pregnancy losses annually, and 80% of those are occurring in the first trimester. So this diagram here gives a more global and general view of the extent of fertilizations, implantations, and then the 10% of the clinical pregnancies losses that we are generally aware of, and then 30% of live births. So that 10% clinical recognized pregnancies would kind of add up to 1 in 4 pregnancies ending in pregnancy or in spontaneous abortion, but we generally say it's 1 in 5. So emotional care is essential to the midwifery model of care, and it's important to know what this pregnancy meant to your client. Most pregnancies are deeply desired. Occasionally there was ambivalence or it was an unintended pregnancy, so it's possible that you may be caring for somebody who experiences relief, but getting that understanding can help you further in your counseling and support of them. So assessing their support system and what the situation is with their partner. Perhaps they grieve completely differently, and offering anticipatory guidance about this can also support their grief process together separately and moving toward their healing. Normalizing a range of emotions, because they may experience every variety of emotions, and that can be helpful for them to know that they're not alone in that. The empowering them with information and options is really what this talk is about, because up to now there's not been a wide movement of being able to have all the available options explained to you, and then for the individual to be able to have access to a provider and make a choice about which option they prefer and would like to have, and to be able to actually access that. option. And then also understanding what the plans are for future pregnancy. Perhaps they're not emotionally ready for another pregnancy at this time, or they are not intending to be pregnant again soon. So here is just a generalized background miscarriage risk graph. It's saying that the background risk is 20%, and after you've had one miscarriage, that your risk is essentially the same. Another miscarriage, it goes up a little bit, but it's not statistically significant. But having 3 in a row is very much so. And these are consecutive losses. Occasionally, or frequently, people have normal, live, healthy pregnancies that result in live births after an early pregnancy loss. So this diagram is the natural history of miscarriage. I like it because it can be used as a client education tool about what to expect with pain and bleeding, but it offers us to also be able to look at the different types of early pregnancy loss. So the one in the middle with the number 1 above it, that could be a missed abortion or an embryonic pregnancy. So it's essentially one where there's been an embryonic or fetal demise, or the embryo never developed and it's just the empty sac. And those generally don't resolve as easily on their own. The next one is a threatened abortion, and so that one there's bleeding, but the cervical os is closed. So those could be subchorionic hemorrhages that can result in pregnancy loss, but they often resolve normally. It could be ectopic pregnancy. It could, except it's in the uterus. It could be any sort of that. So the next one is an incomplete or in process pregnancy loss. So that one is definitely going to complete to terminate and empty the uterus. The incomplete pregnancy losses are very successful if there's nothing done added to support their management. So individuals who are in process of having a pregnancy loss and the cervix is dilated and there's tissue passing, they're very likely to go on to resolve on their own. And then you can also see the bleeding and pain spectrum and what can be expected with that. So the causes of early pregnancy loss, 30% of them are anembryonic. 50% are due to chromosomal abnormalities. The chromosomal abnormalities are largely trisomies, so 13, 16, 18, 21, as well as there's also polyploidies, so beyond the trisomies. The number 1 type of chromosomal problem is factor X. Occasionally, there are live births to female children and it's also called Turner syndrome. There's host factors, so that could be with the uterus, a structural anomaly, fibroids, septate uterus, or endocrine issues, diabetes, for instance, thyroid problems. Those are known to increase the risk of pregnancy loss. And there's many are unexplained, and then we're learning more and more about paternal factors as well. So the clinical presentation of early pregnancy loss, we have bleeding, pain and cramping, falling or abnormally rising beta HCGs, the decreasing in the symptoms of pregnancy, and on exam you might see dilation, pregnancy tissue at the os, or no symptoms at all. The ultrasound findings of early pregnancy loss, here we have an image of an anembryonic gestational sac and then an embryonic demise. So with the demise, there is a little embryo there, and on ultrasound, there was no cardiac activity when that embryo was 5 to 7 millimeters, where you would expect to definitely be seeing it at that time. So the management options for early pregnancy loss are expectant management, which we're all very familiar with, medical management, frequently with misoprostol, and procedural management in the outpatient setting with a manual vacuum aspirator. The fourth option for management is the traditional commonplace one of operating room management, and that can be, again, with either the manual vacuum aspirator, an electric vacuum aspirator, or dilation and sharp curettage, which is really discouraged to use the sharp curettage instruments, but many physicians do what they want in different parts of the country, or it's what they were trained in, but there is a much higher risk for complications with that method. But that does continue to this day, and that is most frequently with general anesthesia. So Dr. Robin Wallace has done extensive research on patient preferences and satisfaction. And so she has developed this guide for all of us who work with pregnant people who might experience a pregnancy loss, so that we can use it when we're counseling them about these management options and figuring out what is most appropriate for them. It's got 5 dimensions, and these dimensions include what are her personal priorities, her medication and procedure related factors. Perhaps she doesn't handle medication okay, perhaps she does not tolerate pain well, perhaps she doesn't want a procedure done to her. Or she wants it to be timed and wants to still be able to have support people there, and so on and so forth. The time and cost priorities. These outpatient procedures can be very affordable as compared to the great expense of operating room management for an early pregnancy loss. So that could be something that could be spoken about with them so that they can figure out what is best for them. And they might want something that's on a weekend because they use public transit or are teachers and can't just wait for expectant management to happen, but they may also not want the procedure at all. As much as possible if they can get away with that. So symptoms of pain and bleeding, and then also if they've had any past experiences with abortion or miscarriage, talking with them about how that might play into their preference of management at this time, as well as how that might affect their coping, grieving, and healing. So counseling steps, the first one, inform them about what's going on, inform them about the management options, gather information from them about what's important to them and what they would like from you. Offer verbal and written instructions. A lot of times there's just high emotions going on, and it can be hard to absorb and take everything in. So being able to hear something and then also have instructions that they can use later on when they're at home or discussing it with family members or other support people can be valuable. Ruling out ectopic, because they are lethal if they rupture and aren't identified. So it's important to be aware of that. Any bleeding, cramping on one side or another, other signs and symptoms that just aren't following the cramping and bleeding normally. Recommendation for RhoGAM for those who are RH negative, and for that to be given within 72 hours of the onset of bleeding. Providing contact information to be available to them for any questions or concerns throughout the process can be very important and valuable. Warning signs, what they need to look for depending on what type of management option they have chosen. You want to keep them safe and have as good an experience as possible that they can given the circumstances, knowing when to call you, when to go to the emergency department. And indicators of completion and the follow-up plan, whether you're going to be touching base by phone or and definitely making an appointment to come in after the miscarriage is complete. And I am going to turn it over to Marnie, and she is going to review the expectant management portion.
Hello. So good candidates for expectant management need to be ideally less than 13 weeks gestation, and that should be by sure regular normal menstrual period or ultrasound. They need to have stable vitals, no evidence of infection happening, no fevers, no increased risk of excessive bleeding, and it is best to rule out ectopic or molar pregnancies, which is done by an ultrasound, and a lot of our clients don't want to do that, but that is what is suggested. And if complications arise, they need to know that they might need to have some sort of aspiration procedure. And complications have to do with fever and excessive bleeding. The process can actually take several weeks, up to 8 weeks. The research that I found didn't go beyond 8 weeks, but it can take a long time. And it is actually really helpful if you get an ultrasound to find out what kind of miscarriage is happening. So if it's a missed miscarriage, they tend to take longer, or sometimes for some reason don't come out at all. And then if it's inevitable, it's more likely to work, just by waiting and seeing. The bleeding should lighten and lessen after about 3 to 5 hours. They can elect to always change their mind. So they can always try this for a few weeks, and then they decide, like, well, I have to go to work, or I have to go on vacation, or I can't just wait and see what happens and start bleeding randomly on the bus, So they always have the option to change their plan. It may not complete naturally. Most of the time it does, but we're not really sure why. Sometimes the body just holds on to it. There is a period of time when you should be checking in with the client during the expectant period, and recommendation is a follow-up visit 1 to 2 weeks afterwards. Do you want to talk about the success?
Sure.
Okay.
Sure. So what is success? So definitions used in studies is this, you'll often see this less than 15 millimeter endometrial thickness. So this was just like an arbitrary number that was developed when they got ultrasound and started looking and seeing, and they just thought, well, 15 millimeters looks good, and so we'll go with that. But actually, if there's other studies that have compared that 15 millimeters to the absence of a gestational sac alone, and it showed in the absence of the gestational sac is what you're looking for, because that's what can cause the ongoing problems for the person. They found that over 80%, like 84%, pregnancies losses were complete with absence of the gestational sac alone, but only about 50 were deemed complete by this 15 millimeter endometrial thickness. So it's not a really good measure. What you're looking for more on ultrasound is that it's homogeneous, that the uterus is contracted and firm, and it's not like there's not a lot of clots and vacuoles and liquid in there, and it's not round and just a bunch of stuff. So that's that. There's no vaginal bleeding have been used in studies, negative urine beta HCG, and as I mentioned, the absence of the gestational sac. So when to intervene for expectant management? A continued gestational sac, clinical symptoms, patient preferences in time. So when not to intervene is vaginal bleeding, because that can go on for 2 to 4 weeks, and some individuals can go on spotting until they have their next menses. So not a good idea. Beta HCG has a really long half-life, so that can continue as well, and so that's not a good indicator of complete, and no need to intervene there. And then again, the endometrial thickness greater than 15 millimeters. Basically, clinical symptoms and patient preference are the key takeaways on that. So medication management. The prerequisites for treatment with this are very similar to expectant management, with the exception of the willingness to accept additional side effects, perhaps more nausea and vomiting from misoprostol, perhaps more pain or discomfort, possibly from the increased intensity of the process. Thank you. Okay, and allergies to the medication. If they have any allergies to misoprostol, which it would maybe be hard to find out until they had tried it, but that's a contraindication. Otherwise, under 13 weeks gestation by ultrasound dating. You don't want to go by last menstrual dating because it's it's a pregnancy loss. So by dates, it could be 17 weeks, but the pregnancy actually stopped going at 10 weeks, for instance, or 11 weeks. So that's not a really good marker of when someone can have this treatment and when they cannot. Vital signs being stable is important, and again, that they may need an aspiration if this doesn't complete on its own. Studies with preference have shown that the people who are most dissatisfied with management, they were kind of randomized to different methods, or they wanted maybe medication or expectant, and they ended up needing the uterine evacuation with the MVA, and so they were the least happy. So providing the anticipatory guidance at this time that it may not resolve on its own, and you may need an aspiration procedure in the end, can be helpful in that scenario. So misoprostol increases uterine contractility and softens the cervix. It's a prostaglandin E1 analog. It's FDA approved for gastric ulcers. It's also FDA approved for in the medication abortion regimen, but it's not FDA approved specifically for early pregnancy loss, and it's used off-label for many OB-GYN indications. It's designated an essential medication by the World Health Organization because of how important it is in being a life-saving medication, being able to stop hemorrhage post-childbirth, and its ability to be out at room temperature, not needing refrigeration, that it's very cheap, and that it can be used by so many different routes, orally, sublingually, buccally, vaginally, rectally. I don't think I missed any. Anywhere where there's a mucosal surface that you can access, you can probably use misoprostol. So other things that are or have been used for medication management include mifepristone and misoprostol. So mifepristone is the other medication in the abortion medication regimen. It's very hard to get that medication, and it's very expensive. And there have been no studies head-to-head with the mifepristone and misoprostol, just comparing it against misoprostol. So what we find sometimes is that settings that have it use it, but at this time there's no reason to think that it's better or to not use misoprostol alone. And then methotrexate and misoprostol, that could be used, that has been used, and other countries might continue to use that for miscarriage management as well. So the process is that the patient can take 1 to 2 doses of 800 micrograms of misoprostol. And the idea is that they take 1 dose and then wait 12 to 24 hours. And if they didn't have the miscarriage symptoms of bleeding and cramping within about 1 to 4 hours of having taken the misoprostol, that they should take another dose after 12 hours, but before 24 hours. And the preferred route for that is buccally, and I'll share more about that shortly. So a really great positive to medication management is that they can control the timing of this. They can do it on a weekend. The children can go to their aunts, and they can have their support people, have privacy. So it's really nice in that way. And they can, again, elect aspiration at any time, and they may also need to if the process doesn't complete on its own. Medication overall is effective 90% of the time. And we recommend a 1 to 2 week follow-up. And again, they're going to have the provider's phone number who's caring for them so that they can call with any concerns or issues that come up, and also warning signs of what to look out for when to call or when to go to the emergency department. Here is 2 graphs about misoprostol by route of administration. And the nice thing about them, what they demonstrate, is that you can see on the left one that is showing the different routes in the serum levels. And with vaginal and buccal, they're the kind of blue and purple. You can see a slow rise and then a steady plateau to a slow descent. So that's saying that buccal and vaginal administration of misoprostol just has, it doesn't spike up into a high concentration. It just rises steadily and stays steadily over many hours, so that the effects can be achieved without additional side effects that you might get with the oral or sublingual, which is where you're seeing the sharp spikes and then the crashes. So it definitely can reduce the negative side effects of nausea and vomiting and feeling ill and not well. And again, with uterine activity over 5 hours, you can see the comparison of vaginal administration to buccal administration. So side effects and complications, we've discussed these to a degree with the misoprostol versus a placebo: increased nausea, vomiting, and diarrhea, and increased pain and discomfort, but no changes in the hemoglobin concentration, and infection, slightly higher infection for misoprostol, and it's not known in this study whether it was administered vaginally that has a slightly higher rate of infection than buccally. And they showed that there was no benefit with repeat dosing at 3 to 4 hours versus that 12 to 24 that I mentioned earlier. And 90% of the individuals found this to be very acceptable. They would do it again, and they would recommend it to friends and colleagues, again showing that when they're able to be counseled on the options, have the option that they choose, that satisfaction is generally really high, even despite some side effects. So the bottom line is the 800 micrograms of misoprostol by vagina or buccally, repeated 1 time at 12 to 24 hours if not complete. And infection prophylaxis, 1 dose of doxycycline or 1 dose of azithromycin. And for pain control, they'll receive prescriptions for ibuprofen, which they can take for a few days, 3 times a day at 800 milligrams, and then hydrocodone or oxycodone, so Norco or Percocet. And the measures of success are the same as with expectant management. So clinical signs, no clinical problems, and no infection, no complications. So, and no gestational sac. So this is the graph for expectant management and misoprostol. So you can see along the top, the first 3 columns after the title column is day 7, day 14, and day 46 for expectant, and then for misoprostol by day 8. The backstory on that misoprostol by day 8 is these individuals were given 1 dose of misoprostol, and if they had not completed their miscarriage by day 3, they were given another dose, and then they had a uterine evacuation on day 8. So that's what's happening in the misoprostol category. But I like this because it's a nice way to look at the different types of pregnancy losses and the efficacy of the different management types, short of the manual vacuum aspirator. So you can see across the board that with the incomplete abortion, that the success rates are much higher for both expectant and misoprostol. But you'll see in order to get to 90% with expectant management, that's out to about 6 weeks. So with the embryonic demise, also known as the missed miscarriages, here you've got 30% will resolve within 1 week. With expectant, that doubles by 2 weeks, and it goes up a little bit more by day 46, so 4 weeks later. And for misoprostol, 88%. And the anembryonic gestations are the most difficult to be managed successfully with either of these methods. But with expectant management, it's very low, even at 6 weeks out, with the 66%, misoprostol with 81%. So that can be a very important thing to share with your clients when they have had an ultrasound and you know that it is an anembryonic pregnancy, which is 1/3 of the pregnancy losses. And if they're very deeply wanting to do nothing and do expectant management, that it's got this lower success rate. And so you can start the conversation and then about what to do if it continues or if there are complications. So uterine aspiration. Who should have aspiration management? Anybody who's unstable, significant medical morbidity, infection, risk for heavy bleeding, coagulopathies on Coumadin, anyone who wants it. So who's eligible for outpatient management? Again, the first trimester parameter, stable vitals, no evidence of infection, no increased risk for excessive bleeding, ruling out the ectopic. Women of size and those with uterine anomalies can be very difficult to manage successfully in an outpatient setting. It might be better to counsel them that medication management might be better because they can have more success without having to go to the operating room if that's what they want to avoid. But in the operating room, there'd be more resources and tools to help them have a successful procedure. And those who are psychologically stable. So people with really high anxiety that can just absolutely not tolerate an outpatient procedure should not be candidates for outpatient uterine aspiration management. This is the instrument tray setup. Very few instruments, a very similar process to an endometrial biopsy. And the process actually takes 2 to 5 minutes. Again, infection prophylaxis and pain control, and adding an anxiolytic, so that's Ativan or Xanax for anxiety for those who would like it. This is a very simple depiction of the 10 steps of performing a manual vacuum aspiration. And complications with trained providers, they're very rare. It's 98 to 99% successful. There's very rare complications in the first trimester with this procedure, and the risks increase with advancing age. And compared to complications in pregnancy, they're very low. Here you can see that there's the benefits of the timing. It's an observed therapy. You're not letting somebody go home and have pregnancy loss on their own. And it has very high success rates. So the post miscarriage care, the ROGAM scheduled at the time of the procedure within 72 hours. Pelvic rest for 2 weeks is recommended. And then they can initiate any type of contraception they want at that time, including IUDs if they're not intending to become pregnant again in the near future. And they can expect the light and moderate bleeding, maybe even into their next menses, with fertility returning rather quickly, 3-4 weeks out. The negative beta HCG around 2 to 4 weeks, and offering appropriate resources and grief counseling on an ongoing basis, because grief and healing can evolve over time and have different needs. Scope of practice, who can do what to whom in what settings and under what conditions. This whole concept came out of in the early 1900s when the medical profession was professionalizing, and they had education institutions that were teaching all manner of things. Somebody could just basically be wealthy and say, I'm going to be a doctor. Other people did apprenticeships, and there were a lot of other things going on with our health and maternal mortality, morbidity in our country at that time. And so they did a big study, and they standardized their medical education. And at that same time, they also made medical practice acts all across the country, starting in New York, that said that as physicians, they could control caring for the mind, body, and spirit of everybody. And so we are all always carving out of that. And it's also used a lot for turf wars and different types of things. But that's where we are. It varies by state and country. For instance, the International Confederation of Midwives would say that all of this that I've spoken about is in midwifery scope of practice. But in our country, we have to go by our training and education and experience, the professional organization standards, and the legal and regulatory constraints that we're under. And I'm going to turn it back over to Marnie to introduce her guideline.
So I'm just going to do a very brief introduction to what we covered in the guideline because I'm going to make it available on the MAWS website if anyone wants to find out deeper information about it. So I narrowed my audience to licensed midwives in Washington State just to make it a doable project. So I used, there's a definition page of commonly used terms. There's signs and symptoms of early pregnancy loss and how it's usually diagnosed. It goes through all of the management options and how to explain them to your clients. Like we already went through there's a chart on good candidates and contraindications for people who want to try expectant management. There's pros and potential cons to expectant management. And then it goes through suggestions on routine clinical care, including office visits and phone contacts, but obviously it's going to be tailored to your practice if you decide to use it. It also includes some recommendations for rituals after loss. It talks about follow-up care, including birth control methods if they want to do that or if they're wanting to get pregnant again quickly. It talks about what complications the midwife and the client should be looking out for and what kind of contacts they need to have when those things come up. Talks about the spectrum of expected and potentially really complicated grief reactions to pregnancy loss, and then the emotional support that licensed midwives can give to their clients during those times. There's a big list of referral and co-management resources and a sample handout for clients explaining expectant management and what they need to look out for during the process and afterwards, and what happens if they change their mind. That can obviously be tailored to your practice as well. And then the one part that I was really most excited about during this whole process was finding out more about complementary alternative medications or management options. And there's not a lot of research, and it was a difficult thing to find out. And a lot of the things that could be used to help a miscarriage pass can also be used for an elective abortion. So there's a lot of stigma about putting that kind of stuff out there, and then there's no research. So I found some, and anybody who uses it is going to have to, have some knowledge or some co-management stuff to help a client through that. And then we put in some over-the-counter stuff that people can use too for pain and sleep and anxiety and stuff like that. One of the really cool things that I found while doing the literature review is I kept hearing a lot of licensed midwives on forums and other places asking like, well, how long is too long to wait? And so I was like, where did this 2-week rule come from? And almost all of the information I found talks about this 2-week rule. And it's kind of arbitrary, like we don't really know why. It's not necessary to just call it unsuccessful after 2 weeks. If there's no sign of infection or fever or heavy bleeding or extreme pain, And the client wants to continue to wait and see what her body will do. It's totally safe to do that. So the guideline really has like specific things that you should look out for. And otherwise, it's just normal to take a long time sometimes. So that was pretty nice to hear that our bodies know what to do most of the time. So, yeah. And then some of the complications that can come up, like I've already mentioned, is severe or prolonged emotional distress, depression, or grief reactions. Should probably get a consultation or referral. Things like fever, uterine tenderness, foul-smelling discharge, all of that are signs of infections, just like postpartum. Anything hemorrhage, soaking 2 menstrual pads in an hour. We all explained that to our clients after a birth, so it's the same thing here. Severe pain anywhere. If they're just like not tolerating the pain and it's going on a long time, they might need some extra help. And especially if it's not controlled by over-the-counter pain medications. Some of the over-the-counter allopathic options and the CAM options I came up with are for pain management, sleep, stress, anxiety, promoting the body to let go of the pregnancy. Bleeding, which is kind of tricky because you don't really want your clients just taking care of a hemorrhage with some tinctures. There's some advice there that you need to like be really clear about, you know, but there are some herbal treatments that can help with bleeding. As we all know, we use it after birth. And things like fear, homeopathy can help a lot with fear. And that's about it. I'm going to make it available. Some of you have already seen it. I've asked for feedback and I appreciate everyone who replied. And I'm really glad this project's over. It's available. There's a question.
And lastly, I just wanted to say that this was such a cursory overview, but these are great resources for you to go and get more information. The Innovating Education Reproductive Health actually has the early pregnancy loss modules, and there's continuing education associated with that, but it goes from the management options to counseling on them to complications to low resource settings. The miscarriagemanagement.org with TEAM, that's got a lot of how to implement different things in your settings, protocols, what have you. IPOS has an enormous wealth of resources. So, and a book for midwives by Hesperian Foundation, and probably Where Women Have No Doctor have complete information also for all of these options. So there was a question? Yes.
I can't remember anything specifically, but none of the research I looked at anything beyond 8 weeks, and basically said if it's not complete by 8 weeks, then you should probably consider uterine evacuation.
No. Okay, yes. So the question was in your research, did you find anything on the increased risk of DIC with longer waiting? And Marnie said no, there was generally these 8-week, 2 to 8 week cutoffs with most everything. We did extensively search, and the thing is most people don't wait that long, and there's not enough people that have been willing to wait that long. I mean, that one study had 46 days, so that was 6 weeks. For these things to happen. But the general idea is that a lot of that is a little bit more second trimester, perhaps. And we consulted with Dr. Prager on it. We all, thought that the stone baby concept was, I don't know if you all know what stone babies are, but basically babies that calcify and that were never born, that some people, I guess there was one in India that there's a documented case of. In my personal experience, I've cared for somebody who had been cared for somewhere else and expressed that her process didn't complete. She wasn't given support and resources. And so she was basically just expectantly managed for a really long time until she did pass this very thing that was calcified like a rock. So the longer that you wait, the tissue can get harder and firmer and more difficult and painful to pass in that way and maybe calcify in these ways. But there was nothing coming up about increased infection or DIC in the first trimester losses. Okay, so that question was, is there a timeline where medication is going to work better than another? So that is something that in all of this research, time of diagnosis, like the time of diagnosis could be 2 days after it became a non-viable pregnancy, or, you know, the person received regular prenatal care and they're now at a 12-week visit, for instance, and there's no fetal, there's no heartbeat, you know, so that time of diagnosis when they go maybe to get an ultrasound could be 5 weeks after. So I don't think anyone's really touched that, and the rates of medication management with the misoprostol for the anembryonic and MIST are similar as well. So I think if it's taking a while from diagnosis, it's one of those diagnoses, and that's what you can expect there. And okay, yes.
If it seems to be taking a long time, I always rule out molar. Just saying.
Okay, thank you. So if it seems to be taking a long time, molar is always ruled out. And do you do that with beta HCGs or ultrasound or both? Mm-hmm. Mm-hmm. I believe that that is standard of practice because it's very similar to medication management, and sometimes there's arguments about these types of things that go back and forth. And for instance, like the pelvic rest for 2 weeks, there's no evidence there. There's not evidence about decrease of infection with swabbing the cervix with something other than normal saline. You know, there's certain things that are done because it seems more safe. But the antibiotic prophylaxis with the procedure definitely do. The other stuff is a little bit controversial, and maybe to support if they are doing the vaginal administration of the misoprostol. Yeah. Yeah, I hear you on that one.
I really think it.
Mm-hmm. Mm-hmm. Yeah, and on that one, it's unclear. Like, I know it's increased rate of infection with the vaginal administration. So some of the stuff is just not all teased and parsed out into nice compartments of algorithms, if this, then that. But it's definitely prudent because a provider is doing something, making recommendations about something that is an intervention beyond expectant is what I would say. Yes.
I live in a rural area where there's a lot of institutions and people who are pro-life, so we don't have a Planned Parenthood, and I don't know anyone who does aspiration in our county or the surrounding county. But we do have some people with family, in Seattle. So where would you refer someone here if they wanted to do that?
So in Seattle, I know that Dr. Sarah Prager and I know that Dr. Emily Godfrey are both in the University of Washington system, and this care is integrated into their women's health care setting. So Dr. Godfrey and Dr. Prager, and I'm sure they have other colleagues at Roosevelt for Women and in Northgate Clinic, and so they're offering that. We've also been doing these miscarriage management trainings for years, and like for instance, Neighbor Care is working on doing it for their clients, and that's going to be a midwife-led thing there once the family medicine providers are trained. Country Doctor and Carolyn Downs are working on it. And a lot of different settings are. So I think a next step is for all of us to figure out who these individuals are offering these services so that we can have a form of a referral list. For instance, I know that we've done trainings in Yakima and they invited people that came down from Ellensburg and I thought Wenatchee. So you may actually have some resources in the area. You're just not familiar with exactly who they are. But those are some providers here in this community who are either offering or wanting to offer the aspiration procedure in the primary care setting. Additionally, there's Cedar River and the Planned Parenthood, and there used to be the Aurora Medical Services, but not all clients would want to go to a clinic that provides abortion services. So.
Last question.
So that's great to know because those freestanding clinics might be under $1,000, under $600, but I'm not aware of what the facility fee is at the other place, but an operating room fee could be many thousands of dollars. Mm-hmm. 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 And Cedar River. In Cedar River, we have worked with them as well, and they are working on having a specialized miscarriage management. Like I think they even have a separate waiting room, and they're really wanting to tailor those services to those clients.
I personally used to work for Dr. Charlie Brown at All Women's Health North up in Northgate area, and he sees a lot of people there that are not there for an elective abortion, a lot of fetal demises, a lot of miscarriage, a lot of later term gestation stuff. So I think it's all about telling your clients that you have no idea why these women or people in this waiting room are here, and it's not all about unwanted pregnancy. So I think that's an important thing to tell them when they're going to a clinic like that. We have to stop so everyone can eat. So thank you so much.
Okay, real quick for all of you who are out there watching us online, if you could please sign out and then sign back on the second link after lunch. Also, Amanda will be working on putting all the PowerPoint slides up on the site, and we'll send out an e-alert. And finally, hopefully by this evening, the whole presentation will be uploaded onto the MAWS YouTube site. And don't forget about the raffle.
Can you help me get this?
There it goes. I like how